Afternoon. I am Rosemary Martinez, Senior Board Director for the Board on Population Health and Public Health Practice, under which the Roundtable on the Promotion of Health Equity sits here at the National Academies of Sciences, Engineering, and Medicine. Welcome, and thank you for joining us today. It is my pleasure to introduce today's moderator, Dr. Winston Wong. Dr. Wong is the chair of the Roundtable on the Promotion of Health Equity, and he's a highly respected health equity leader and public health advocate. Dr. Wong, I will turn the meeting over to you.
Well, good morning, everybody. At least it's good morning for me here in California. And certainly we have brothers and sisters from across literally the globe. So there are folks that have yet to have coffee. All right, well, let's get started. I am Winston Wong, and I'm certainly honored to be the chair of the Roundtable on the Promotion of Health Equity here at the National Academy of Sciences, Engineering, Medicine, more specifically the National Academy of Medicine. I want to welcome all of you to today's webinar on COVID-19 health equity and the Asian American, Pacific Islander, and Native Hawaiian communities. Part 2 of this webinar will take place on Thursday, December 9th from 12:30 Eastern Standard Time to 3:30 Eastern Standard Time. And I invite you certainly to join us for the second day on Thursday. Both of these sessions are intended to be not repetitive or redundant and feature notable nationally recognized leaders in Asian American, Native Hawaiian, Pacific Islander health. Certainly, if you're unable to join us, those sessions will be recorded, and I would encourage you to spread the news about the second session among colleagues and friends in your professional network. This webinar today is suggested by the title, focuses on the unique obstacles faced by the Asian American, Native Hawaiian, and Pacific Islander communities. Previous webinars hosted by the Roundtable focused on African American, Latinx, American Indian, and Native Alaskan populations. Today's webinar will be recorded, and the archive video will be available at the link provided at the end of the webinar. This webinar is an important and long overdue first for the National Academies of Sciences, Engineering, and Medicine. In all of the years of its existence, the academies have never conducted a project that focused specifically and solely on the NHPI communities. Long-term time coming, and certainly something we want to make sure is disrupted in the future, so the issues of this community are continually revisited and brought forward for the nation's public to really understand and to move forward on. Throughout the pandemic, there have been reports of increased incidents of xenophobia and violence against Asian American, Pacific Islander, and Native Hawaiian community members, particularly women. They are significant and well documented, and they represent increases in anti-Asian American, PI, and Native Hawaiian hate speech and assaults. Members of these communities report a heightened fear of reprisals, slurs, physical assaults, on top of the anxiety present through living through the COVID pandemic. The incidents have resulted in many mental health issues, as well as physical exhaustion, even fatalities, sadly. During the pandemic, the Asian American, Native Hawaiian, Pacific Islander communities have also faced the lack of availability of culturally and linguistically competent healthcare. Healthcare providers offering vaccination, testing, and mental health services often lack the ability to provide access to the range of languages spoken by subgroups. This can contribute to a reluctance to seek needed healthcare in the midst of the pandemic. Today and Thursday, we will explore the impact of two convening epidemics, the COVID-19 pandemic plus the epidemic of racial discrimination and violence on the health and well-being of the AAPI Native Hawaiian population and potential strategies to mitigate them. I will also add that we will touch upon the historical framework that's needed to understand the context of xenophobic and racist attacks on this population. Before we begin with today's keynote presentation, I'm extremely honored to share some brief welcoming remarks from the President of the National Academy of Medicine, Dr. Victor Hsiao. Dr. Hsiao also serves as the Vice Chair of the U.S. National Research Council. He is Chancellor Emeritus and the James B. Duke Professor of Medicine at Duke University, and the past president and CEO of the Duke University Health System. At the National Academies, Dr. Hsiao has designed and led important initiatives such as the Commission on Global Health Risk Framework for the Future, the Human Genome Editing Initiative, the Vital Directions for Health and Healthcare, and the Action Collaborative on Countering the U.S. Opioid Epidemic. And by the way, longer biographies, including Dr. Hsiao's and all our speakers, will be available in the workshop materials. So it's my great honor to introduce Dr. Hsiao for his introductory comments. Dr. Hsiao.
Thank you very much, Winston, and thank all of you for attending this really important meeting. And I look at my good friends, Howard Cole, many others speaking. I'm just so excited about this. You know, being Asian American, this topic is important and meaningful to me personally. So I'm really grateful for the HMD Roundtable on Promotion of Health Equity and Kat Anderson for convening this workshop. You know, it is really important to highlight these epidemics that influences the AAPI-NH community. Too often, we don't get the attention that we deserve. Even in my own organization, as Winston said, there's never been a project focusing specifically on the AA-NHPI communities. And this is the first one. I'm sorry to point out that Asian Americans are not notably listed or notably not listed as a vulnerable population under National Academies criteria. For example, in our recent framework for equitable allocation for COVID-19, we were never mentioned. And our community continues to be consistently included in COVID-19 response policy. Many view our community as a well-educated, high income, but I think this perception obscures many issues. This kind of stereotyping obscures the fact that large portion of API NH population are poorer and vulnerable. For example, immigrants living in Chinatown and many others. Asian Americans are the most economically divided racial ethnic groups in the country. As a whole, Asian Americans have the highest household median income. However, there's a highest rate of income inequality. For example, in 2016, Asians ranked in the top 10 percentile. Asians in the top 10 percentile earn 11 times as much as those in the bottom 10 percentile. If you look at other trends, rates of unemployment, education, attainment, actually they're very much similar. So I think the AAPI NH community is more vulnerable for reasons mentioned above. And other factors also come to play. Language, health literacy barriers. You know, 69% of Asian Americans are born outside the United States, like me, and almost a third have difficulty with English. Jokingly, I'm still having difficulty with English. But social isolation, because you don't speak the language, the lack of a network, culture, the mistrust of healthcare, delay, reluctance to seek help, are important factors to consider. And there's just not enough conversation around this topic. COVID-19 disproportionately affecting many groups. We all know about Black and Latino communities, but guess what? It's affecting API NH community in a big way. But I would be first to say there's a lack of systematic data collection and much less known about infection and vaccination rates in this population. But whatever data we do have indicates they may be disproportionately affected this population, our population. In at least 16 states that disaggregate COVID-19 data by race, ethnicity, Native Hawaiians and Pacific Islanders have the highest mortality rates in those states, including California, Minnesota, Washington State, and Colorado. And then, although Asian Americans tend to have low rates of infection with COVID-19, the proportion of deaths from cases is especially high. The case fatality rate in Asian Americans is 3 times that of overall population in California. That's 8.4% versus 2.6%, exceeds 10% in Los Angeles, Chicago, New York City, and New Jersey. And in San Francisco, Asian Americans comprise just 12% of positive rates, cases, but make up nearly half the deaths. That's the data I got, even though it's not totally systematic. But it does tell you that we need to put more time understanding this issue. I think that, as Winston pointed out, the last 20 months, the AAPI NH community have faced additional burden, the rise of hate and bigotry. There have been reports of increased incidents of xenophobia, as he said, violence against our community members. And in fact, analysis of hate crimes is 16 America's largest city. Revealed that such crimes in 2020 actually decreased overall by 7%, but those targeting Asian people rose by 150%. And of course, we all know that anti-Asian discrimination violence associated with increase in, as Winston said, mental health, anxiety, depressive symptoms, and many others. So I just feel this is such an important issue. And of course, for me personally, it is so important. And I know I've spoken to some of you who actually are speaking up to this, speaking out on this issue. To me, in summary, to advance equity for all, we must address equity of health for every population, in this case, Asian American, Pacific Islander, and Native Hawaiian communities. We know that COVID has disproportionately affected this population and also fueled an anti-Asian American racism. So it's imperative for us to address the issues at this meeting and advance the health of our community. And it highlights the need to look at unique challenges facing every population. So thank you for allowing me to speak to this subject that means a lot to me. And I can't thank you enough for organizing this meeting. So back to you, Winston.
Dr. Shao, I want to just say how much we salute your leadership at the Academy, and for you to take some time from your very busy schedule to acknowledge this issue and to weigh in personally actually means so much to me, as well as the workshop organizers and this entire audience. So I hope certainly if you can't join us for the full 3 hours that you'll look back at our recording and look at the workshop proceedings. So thank you so much, Dr. Shao.
Thank you.
Thanks. Next, I'd like to introduce another one of my heroes, Dr. Howard Koh. I need to tell you that I picked up my issue of JAMA back in August of this year and was so thrilled to see a major article written around the issues of the COVID-19 and the issues around health equity facing Asian American, Native Hawaiian, Pacific Islander populations, with the lead author being Dr. Howard Koh. It was thrilling for me to see Dr. Koh, with his stature, really sharing with a national readership how critical these issues were. And incidentally, we have one of his co-authors, Dr. Juliet Chow, who will be also making some presentation at our next webinar on Thursday. But just to talk about Dr. Koh, he is the Harvey V. Feinberg Professor of the Practice of Public Health, Leadership at the Harvard T.H. Chan School of Public Health and the Harvard Kennedy School. He previously served as the 14th Assistant Secretary for Health for the U.S. Department of Health and Human Services between the years of 2009 and 2014 under President Barack Obama. He is a graduate of Yale College and the Yale University School of Medicine and trained at Boston City Hospital and the Massachusetts General Hospital. The title of Dr. Ko's talk today is Toward Healing and Health Equity for Asian Americans, Native Hawaiians, and Pacific Islanders. We will have a short time for discussion and questions following his talk today, and Dr. Ko, I just want to again emphasize how much we value your leadership, and thank you for taking time from your busy schedule to share some remarks before our national audience. Dr. Ko.
Thank you so much, Dr. Wong, for that very warm introduction, and welcome everybody. I'm so thrilled to be part of a historic event for the National Academy of Medicine and for the country. Let me start by thanking Dr. Zhao, my good friend, Dr. Wong, for his persistence and leadership in making history happen today. It's good to see all my friends from the National Academy, Rose Martinez, Kat Anderson. I want to thank Christy Park, who helped organize today and will be running my slides. And I want to make this presentation not only professional, but personal as well, because I'm a Korean American and a son of immigrants. And the issues that I'm presenting for you today are ones I've thought about just about every day of my life, not only as a physician, but as a proud Korean American. So I'll be sharing some thoughts about healing and health equity for the AA-NHPI community through this historic pandemic and beyond, and look forward to hearing from all of you about how we can work together to call more attention to these critical issues. First slide. This statement from the WHO is one I think about almost every day. It's engraved into concrete in 7 languages on the exterior of my school, the Harvard Chan School of Public Health. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being. Every one of us is thinking a lot about what is the highest attainable standard of health through this very difficult time of COVID-19. Next slide. And it's very important that we keep that aspiration in mind as we see the demographics of our country. And you all may know that we are steadily on our way to becoming a majority minority country by 2045. And so today we're focusing particularly on the AA and HPI population, of course. Next slide. You've already heard from Dr. Zhao and Dr. Wong about some of the demographics that make today's presentation important, not only to our community, but to the country at large, because the AA and HPI population nearly doubled between 2000 and 2019. We're projected to surpass some 46 million by 2060. We're the fastest growing racial group in the country. Next slide. But we are not well understood, and we are not a monolith. We are extremely heterogeneous group. We are consisted of some 50 ethnicities, roots in some 19 countries and 100 languages. Dr. Zhao mentioned that most of us are foreign born. 28% are less than proficient in English. 17 represent more than one race or ethnicity. I often reflect that the term Asian American is as useful as the term European American. You have to dig down deeper when you hear the term. And so, for example, we understand that there are 6 subgroups: Asian Americans of Chinese, Indian, Filipino, Vietnamese, Korean, and Japanese background that all have over 1 million in population in our country right now, making up 85% of the AA-NHPI population at large. Next slide. So Dr. Zhao has already mentioned the extreme heterogeneity of our population in terms of income and education, just to take 2 variables. But I thought this very instructive graphic from NPR really made this very explicit for all of us. So if you look at percentage of adults with at least a bachelor's degree on the x-axis and household income on the y-axis, you can see the tremendous diversity within the AA and HPI population by income and education. So for example, on the upper right, you see the income and education represented by the Indian American subgroup of our community, whereas all the way on the other end, groups like the Native Hawaiian, Southeast Asian background, Americans, Samoan, Laotian, Burmese have much lower incomes and educational attainment. So this is just one example of how we have to keep this heterogeneity in mind and not lump everybody together as we have been for far too long. Next slide. So these are all themes that I brought to my service in government, first as the Massachusetts Commissioner of Public Health, and then later as the Assistant Secretary for Health from 2009 to 2014. If I can say, serving the Obama administration was absolutely the privilege of my life, to serve under Secretary Kathleen Sebelius, to serve under the former president and meet the then Vice President, now President Biden, of course. I every day now reflect on my time working with Dr. Tony Fauci, who I believe is a historic and legendary figure, and trying to model the best public health behavior. Here I am on the left getting my flu shot, one of those years at the National Press Club. But through everything I did, I was fully aware that I was the first Asian American and Korean American Assistant Secretary for Health. And I felt a responsibility as well as an opportunity to do something for the AA and HPI community. So some of the slides I'll be presenting next, I will be showing some of the results of those efforts. Next slide. First, from a broad point of view, as the Assistant Secretary for Health of minority background, I was very involved in the health equity issues of the department. You may know that the first health equity minority health report from HHS came in 1985 with the so-called Heckler report. In 2011, Secretary Sebelius wanted an updated action plan to reduce racial and ethnic health disparities. So I had the honor of overseeing that effort for the department and putting out a strategic plan that was put forward in the perspective of the rollout of the Affordable Care Act. Among many things, we created 6 new dedicated offices of minority health at HHS. As you can see, we published our action plan in health affairs over on the right. I had the privilege of co-authoring that with Garth Graham and Sherry Gleed. And then also as the Assistant Secretary, I had the incredible honor of overseeing Healthy People 2020. Healthy People 2030 has now been released. But the goals for the last several decades have been to eliminate health disparities, achieve health equity. And over on the bottom right is a personal photo that I just treasure, a picture of me and my two of my predecessors, Dr. David Satcher and Dr. Julius Richmond, who is another legend in public health. He passed away a number of years ago, but Julie has inspired so many of us with respect to health equity and healthy people. Next slide. So what can we say about AA and HPI today? We are often an invisible or misunderstood population. Not much attention to the AA and HPI community to date, as you've already heard from Dr. Zhao and Dr. Wong. We can all agree that US residents of AA and HPI descent have richly contributed to the nation's social fabric for centuries, but we are still regularly treated as outsiders, as them rather than us, and as foreigners in our own country. I think we all have personal stories to share about that. I certainly do. We're often confronted with the model minority myth, when in fact we are a heterogeneous population for reasons I've already described. We hold a lower percentage of leadership positions within American society, despite making up now 7% of the populations. This is from a New York Times analysis. And we are also underrepresented in terms of political office and in Congress, although we are making progress. So those themes and then the issues of xenophobia through COVID prompted me and my 2 wonderful colleagues, Julia Choi and Jeff Caballero, to write this viewpoint in JAMA, which is published in August, that Dr. Wong has already referred to. Next slide. So in that viewpoint, we do mention some of the themes that are front and center for our community right now. First of all, there has been a very disturbing rise in hate incidents against the AAA NHPI community. The most graphic one was in March of this year in Atlanta, when this young man went to a number of Atlanta spas and killed 8 people. 6 were women of Asian descent, and there were all sorts of headlines, as we well remember. And this hate and discrimination has existed even against some of the most distinguished Americans of our time. So this summer, I don't know about you, but I was absolutely riveted by Suni Lee when she became the first Hmong American to represent the US in the Olympics. There she is in action over on the right. But it was very disturbing to see that last month she was attacked with pepper spray after being accosted by a group in a car in California yelling racist slurs. So this is the state of affairs in our country right now. And we have to face this as a nation who is committed to health equity and helping each person reach their highest attainable standard of health going forward. Next slide. Dr. Zhao has already stated some of these statistics. We are very grateful to our colleagues from San Francisco State University who have set up this database called that's incorporated under Stop AAPI Hate. Hate crimes being reported to the police have increased for crimes against the AA and HPI community, as you can see on the top left. As Dr. Wong mentioned, most of this is against women of AA and HPI background. And this is directly xenophobic, and if I can say racist, because with these crimes, there are often cries of, you brought the virus here and go back to where you came from. That second line really stings, because what happens if you came from the United States of America? How do you respond hearing something like that? And by the way, so many members of the AA and HPI community are affected by this, whether we personally faced the offensive incident or not. There's been online surveys like the one quoted on the bottom, noting that significant numbers of our community have experienced some sort of harassment or incident tied to their race and ethnicity through COVID. Next slide. Now, these hate crimes do not spare AA and HPI health professionals. And there's a deep irony here, because here we have physicians and nurses and other health professionals in the trenches at the bedside trying to save lives. Meanwhile, they are subject to attacks. So here's an example of a Mount Sinai medical student who was assaulted and robbed by a man on her way to work in February of this year. So much to her credit, she organized a rally with over 1,000 supporters in white coats, saying that this is absolutely not to be tolerated in times like this. So there's now increasing attention actually to talk about education for medical professionals and medical students about the issues facing the AA and HPI community, whether that's for patients or for health professionals at large. Next slide. So talking about AA and HPI representation in medicine, I want to thank Dr. Wong for his leadership for the National Council of Asian Pacific Islander Physicians. And over on the bottom right, in the same August 17th issue of JAMA, there was another article co-written by Dr. Augustine Choi and his colleague from New York City about diversity and leadership at academic medical centers. So between our viewpoint and Dr. Choi's, we note that some 21% of US physicians and surgeons are of AA and HPI background. So that seems substantial. But again, if you dig down deeper, you see that the NHPI subgroup are the least represented in US medical schools. We owe a debt of gratitude to the registered nurses who, again, have been heroes in the front lines through COVID. A substantial number of them are of Philippine background, and they have been disproportionately affected in terms of COVID-related deaths in nurses. So we have to pay more attention to that. And then at academic medical centers, we need more physicians and health professionals of AA and HPI background in leadership positions as professors, department chairs, deans, a lower proportion of Asian American faculty members have achieved the level of full professor or department chair from the data that we have from AAMC and others. Next slide. And then I was looking for specific publications on COVID and AA NHPI background. So just after our viewpoint was published in JAMA in August, I was made aware of this very good publication in Journal of JAMA, Journal Internal Medicine from Dr. Tung Nguyen's group in California. Tung has been a real leader in Asian American health disparities work for a long time. And the lead author is Brandon Yan, who of all things turns out to be one of my students, one of my new students at the Harvard Chan School of Public Health. So we had a good meeting, and he reviewed the work that went into this publication that I'm referencing here. We have some data collection issues that we're all going to be talking about today and on Thursday with respect to our population. But we are seeing from some early results from Dr. Nguyen, Dr. Yan, from Brandon Yan and others, and mentioned by Dr. Zhao, that the AA NHPI community have higher excess all-cause mortality through COVID, higher case fatality rates, higher percentage of deaths attributed to COVID, higher likelihood of hospitalization. This is all early data, but now published in the peer-reviewed literature. So we have to figure out what's going on here. What are people of our population presenting later? Is it challenges of trust in the system? Is it a challenge of not understanding about how to navigate the system through COVID-19 and beyond? Lots of issues here for our community. Next slide. And then I just want to make a special comment about the NHPI subpopulation, because this is a fascinating, very important, distinct group and part of the Asian American NHPI heritage. I am putting some pictures in here because as Assistant Secretary, I had the incredible privilege of visiting Chuuk, Micronesia, on the way back from a international conference in Singapore where I represented the United States. I had the incredible privilege of touring Chuuk with the US ambassador to Micronesia, pictured here. And one of the exercises we did on this island was to walk around and walk into some of the community health centers / emergency departments on this island. And we are posing in one of these pictures with several women who are the community health workers who would see you if you needed walk-in care or emergency care on this island. But their facilities would be often a hut with one room with a bookcase with some medications in it. And the ambassador and I are posing in front of this below. That was in essence their pharmacy. And there was a single cot in these huts. So just to show you how the needs of some of our NHPI colleagues are really quite high. And we have to keep all of this in mind through COVID-19 and beyond. Next slide. So as Dr. Zhao mentioned, not every state even tracks NHPI outcomes, but states like California and Hawaii do. And in those states, you see that the case rates for COVID in the NHPI population are the highest of any racial ethnic subgroup. And we've got to figure out exactly what's going on there. Next slide. Next slide, please. And so to get better understanding of this really requires drilling down on better data for this profoundly heterogeneous population that we're talking about, the AA and HPI population. We are not a monolithic group. One of the themes that we mentioned in our JAMA publication was, to our great dismay, if you look at the NIH budget, only 0.17% of it is dedicated to AA and HPI health projects, even though our community makes up 7% of the US population. And for far too long, those of us who have been looking for AA and HPI data have found it to be incomplete, misclassified, aggregated, or simply absent. I'll never forget being a young medical student and physician looking for Asian American data and saying, there is no data, there is a lack of data. In fact, there was an acronym that we used to share with one another, TIALOD, there is a lack of data. How many times have we heard that? And, you know, in our public health discussions, when there's no data, too many assume there's no problem and no disparity, and that's absolutely not the case. So these are some issues that we all need more attention to. Next slide. Now, one aspect of being the Assistant Secretary when the Affordable Care Act was signed into law in March 2010 was this very exciting development in terms of updated data collection standards. And so here on the bottom right, you see that because of the Affordable Care Act through so-called Section 4302, all HHS-sponsored health surveys involving self-reported information required that respondents fill in race, ethnicity, sex, primary language, and disability status. And the options for race in that box on the right were expanded. So there are 7 subgroups for Asian Americans, 4 subgroups for Native Hawaiians and Pacific Islanders. So you could check off for Asian Americans, for example, Asian, Indian, Chinese, Filipino, Japanese, Korean, Vietnamese, American, and other. So we thought that was an advance. And if you look at the data that has disaggregated information for AANH population over the last decade or so, we are slowly seeing more analyses made possible because of Section 4302. And this was a theme that Rashida Dorsey and I and colleagues Garth Graham, Sherry Glee, David Myers, and Carolyn Clancy wrote up for the annual review of public health. Next slide. And then as Assistant Secretary, I had the privilege of touring the Nhpis trailer, the National Health and Nutrition Examination Survey effort, which is a historic HHS effort to collect health and nutritional data for the US population. So HHS and Nhpis began oversampling Asian Americans for the first time in 2011. So that was very gratifying. That was written up by some colleagues in AJPH on the bottom left. So again, some growth for research for our population. Next slide. And so many of my wonderful colleagues today and on Thursday will be talking about other Asian American, Native Hawaiian, Pacific Islander health disparities, about cardiovascular mortality, hepatitis B, and cancer. And I won't go into a lot of that right now, but let me just mention a couple more slides on how we try to address them, certainly through my time at HHS. Next. Here's one I'm very proud of, and it represents a great collaboration between the National Academy of Medicine and HHS, because in 2010, as I remember, Dr. Sam So of Stanford chaired this very important committee for the National Academy of Medicine on eliminating the public health problem of Hep B and C in the US and developing a national strategy. And that was, you know, one of the many, many very important products of the IOM and NAM. But you all know that too oftentimes these reports come out and then there is no follow-up or action afterwards. And God bless Dr. So, he came and presented to the HHS leadership at the time and said, Howard, you're the Assistant Secretary for Health. What are you going to do about this? Can we advise you, and can HHS put out an implementation plan, and can we work together to make these recommendations come alive? So I turned to some of my really dear HHS colleagues, and I just want to thank them by name. Rosie Henson, my wonderful senior advisor, Dr. Ron Baldessari, Dr. John Ward of CDC. And we decided to take up the charge and create an HHS-wide effort, along with support from the advocates, to come up with an implementation strategic plan. That was released in 2011, I believe, with the major goals here. And so that plan exists today, has been updated several more times to advance prevention, reduce deaths, reduce disparities, and coordinate efforts between Hep B and Hep C. This is tough stuff, but it involves education, outreach. During my time there, the so-called baby boomer screening recommendations for people for Hep C was recommended by first HHS and CDC, then later by the Preventive Services Task Force. And so we would like to think that we have developed more coordination and collaboration on these efforts. A lot of efforts in the Asian American community to prevent transmission of Hep B at birth and maximizing the birth dose given in very many birthing hospitals. So it was a great personal honor to be part of that as the Assistant Secretary and as a Korean American. Next slide. And I'll give you an example of how they used me, and I was happy to be used. They said, Howard, okay, you're the first Asian American Assistant Secretary. Let's put you on a poster reminding the American people you got to take care of your liver, particularly the AA and HPI population. So there were risk assessments, outreach in multiple languages, PSAs, next click. But they decided to put my face on all these other posters with the same messages translated in multiple languages. I can't speak all those languages, by the way. But it was great to use my personal background to try to advance this outreach going forward. Next slide. Here's another issue of importance to our population that, for reasons that I hope others can explain better than I, Asian Americans have a higher prevalence of type 2 diabetes risk at relatively lower BMI cut points than whites. So a so-called Screen at 23 campaign was launched a number of years ago to raise awareness for patients and providers. So you can see all the colleagues involved here. I'm in Massachusetts now. The Joslin Diabetes Center was very involved in this, the American Diabetes Association, again, and CAPIP, Dr. Wong's group. So I want to thank all of them. And hopefully this can lead to earlier detection of diabetes and better treatment. Next slide. And then here's a topic that I'm very proud to present to all of you, because as you remember, under the Obama administration, passing and implementing the Affordable Care Act was a major, major priority for everybody up through the president. Right now, we have this map of the United States, still a dozen states that have not expanded Medicaid as of this past September. But it appears that efforts to repeal the ACA now are on pause and hopefully have ended. We will see. But we are very proud of what the Affordable Care Act has done since passage on March 23rd, 2010 to grant health insurance coverage to some 24 million Americans and counting. Next slide. And there was a lot of attention to whether the ACA would decrease disparities for health insurance coverage. And so this is an issue I was following a lot when I was at HHS, and then I came back to Harvard and worked with a brilliant young Harvard public health student, Dr. John Park, and he was my research assistant at the time. And he came to me once after doing a review of the literature and said, Dr. Koh, there have been no peer-reviewed formal analyses of health insurance coverage uptake by AA and HPI populations through the ACA. And I said, what? Can that be right? And we found some informal reports and some letters to the editor, which were very important, but no formal analysis. So we did one. And I want to thank Dr. Park, also Sarah Humble, Ben Summers, Graham Colditz, Arnie Epstein, who joined in this piece published in JAMA Internal Medicine 2018. So as you can see here, there are disparities by race ethnicity in 2009 for health insurance coverage, and a gap between white Americans and AA and HPI Americans. But over time, and especially from 2014, when medication began, that gap closed, narrowed, and then closed by 2016. So by the time this analysis ended, we could say there was no gap. There was no disparity. Now, that doesn't happen very often in public health research, and I would add the caution that we don't have follow-up since then, unless others on this conference have more information. But we're very excited to see that, and we want that to be explained and sustained going forward. Next slide. And then we're also very aware to say that the gap between AA and HPI and whites narrowed and closed is one thing, but what about for all the subgroups that I've been talking about so far? So we looked at adults aged 18 to 64. Next click. And to our great satisfaction, we saw that every major AA and HPI subgroup benefited from health insurance coverage. As you can see over on the right, this got published in Health Affairs in 2019. As a Korean American, if you can look at those figures there, I've been always aware that Korean American uninsurance rates are pretty high, usually the highest of any subgroups for reasons that are still debated. It could be that so many Korean American families are those sponsoring small businesses and didn't have the privilege of and luxury of getting health insurance coverage. Now they do. So to see the dramatic drop in the percent uninsured in Korean Americans through the ACA and beyond has been very gratifying to me personally and professionally. Next slide. So in our piece, we stress that it's very important for healthcare providers right now when they're seeing patients of AA, NHPI background, not to make any assumptions. And if I can say, our community has been subject to too many assumptions for too long. And so we in our piece, myself, Julia Choi, and Jeff Caballero, write that we encourage health professionals not to make assumptions about an AA, NHPI patient's race and ethnicity, their birthplace, their first language, their socioeconomic position, their culture, their spouse or partner, their sexual orientation or gender identity, their disability status or worldview. If you don't know about any of this for your patients, ask and listen, don't assume anything. And you may even want to acknowledge that the pandemic has been tough for everybody, but particularly for the AA and HPI community. And just signaling that as a healthcare provider may signal respect and support for your patients. Next slide. As I close, I am very excited that the White House Initiative on Asian Americans, Native Hawaiians, and Pacific Islanders is being resurrected under President Biden. This was first established under President Clinton in 1999. In the Obama administration, President Obama and Vice President Biden were very active in this initiative. I had the incredible privilege of working with so many great colleagues in government and in HHS through that initiative. There's a picture of our meeting on the bottom left where the president came and spoke to our group. And President Biden has now reauthorized the initiative. And I want to say thank you to Crystal Ka'ai from Hawaii, who's the new executive director bringing this initiative together. They have some initial major goals to address anti-Asian bias and violence, to tackle the issues of the systemic lack of disaggregated data, to expand language access and language assistance programs. And on the bottom right, here's something very exciting to see the president signing the COVID-19 Hate Crimes Act that brought attention to saying that the issues of xenophobia and violence right now against the community are absolutely unacceptable. So I want to thank the president for his leadership. And of course, you see behind him support from the vice president, who of course is of Asian American background, leaders in the Senate like Senator Duckworth and Senator Blumenthal and Senator Hirano, leaders from the House like Representative Judy Chu and Representative Grace Meng. This is some evidence that there's more attention to these critical issues for our community going forward. Next slide. We need to work together with National Academy of Medicine and some very important groups across the country. I've already mentioned Julia Choi, who's the CEO of the Asian Pacific Islander American Health Forum. I've already mentioned Dr. Wong and the National Council of Asian Pacific Islander Physicians. Jeff Caballero, who's been a dear colleague and friend for many, many years at APCHO, doing just historic work for the community. I also want to single out the Josiah Macy Foundation and its president, Dr. Holly Humphrey. I have the pleasure of being a board member of the Macy Foundation. And under her leadership, she is tackling these issues of disparity and discrimination, especially at the medical student education level. And so I want to thank her. Dr. Karen Kim is another wonderful leader for us who's based at the University of Chicago. Next slide. And I close on this small but hopeful sign. This just caught my eye, that the first Asian American Muppet has now been introduced on Sesame Street as of Thanksgiving Day. And this is Ji Young, a 7-year-old Korean American with passions that include rocking out an electric guitar and skateboarding. And the character of Ji Young, the first Asian American Muppet on Sesame Street, was developed in response to the anti-Asian hate crimes and other hate issues that we have seen through the pandemic. Last slide. So I'm hoping that with attention to all these and many more issues from the National Academy of Medicine and all of you, we can continue to advance our common mission of promoting public health, achieving health equity, and making sure that every person can enjoy the highest attainable standard of health. Thank you very, very much.
And thank you, Dr. Ko. Certainly, if we were live, I think we would have a standing ovation for such a complete, comprehensive overview of Asian American, Native Hawaiian, and Pacific Islander health. Your leadership is apparent, and it just literally really sends chills up my spine of your presentation. For the audience, I just want to mention these slides will be available on our site. And also for the audience, I'd like to invite you to enter some questions. We have to the bottom of the hour with Dr. Ko that you might toss up to Dr. Ko for his consideration, fully realizing that all the questions will probably not be addressed during this hour, but for the record, we have workshop proceedings, so it will help inform our planning and our review of how this extraordinary first hour went. So Dr. Ko, it's so apparent that you have really been one of the leaders of health and human services in our country, public health in our country. You've been in positions of influence and being able to draw upon the feedback and insight of our community leaders around Asian American, Native Hawaiian, Pacific Islander health. As we put together the proceedings from this workshop, it'd be really great if you could muse about where we are in this juncture in 2021, also relative to our lessons from the COVID pandemic. What recommendations would be good for us to put forward, and especially since they come from you as our former Assistant Secretary, they might have some additional gravitas if you suggest some recommendations that might inform public health policy in this country.
Thank you so much, Dr. Wong, again. And again, it's a thrill to present before everyone. So as challenging as these issues are, we have made progress. And I think that progress is accelerating despite the challenges of COVID and the discrimination that we have witnessed. I think first and foremost, as we've said repeatedly, I'm sure just about every speaker will mention this, we have to improve understanding of our community as a diverse and heterogeneous one. To make assumptions about any NHPI person is just doing that person a disservice right now. We've all been subjected to assumptions about all kinds of dimensions of our life, and that's not fair. And that's doesn't treat each person as a unique human being with his or her own story. So I think educating people not to make assumptions, but to understand that the NHPI community is diverse and growing rapidly. We are the fastest growing racial group in the country. Demanding better data and research so we can understand the disparities and address them. Building these collaborations through your organization, Winston, the National Academy of Medicine, the Health Forum that Juliet heads, HHS, and others is absolutely key. I'm very excited to see where the White House initiative will lead us now in terms of coordinating with the executive branch and with Congress. I did show Congresswoman Chu in that signing slide, and she has been a champion for our community for over a decade. Anybody who knows Judy Chu knows how dedicated she has been. And again, the leadership of people like her and Senator Duckworth and Senator Hirano and Congresswoman Meng and others has been so great. And then I think in the time of COVID, to understand that, we have a lot of AA and HPI households that are multi-generational. We have these special COVID risks for NHPI populations that we have to drill down on. And then really cultivating leadership in the health professional and medical community world going forward so that more young people can rise up and be future leaders in all this going forward. So those are some of the themes that come to mind for me.
Great, thank you. And we are getting some feeds and some questions are coming forth from the audience, but I encourage people to still use that opportunity. We do have one of our colleagues from Hawaii who wants to point out some of the important work that's occurred at the University of Hawaii School of Medicine, as well as the School of Nursing there and the School of Social Work, that have really focused on the issues of Native Hawaiians and looking at that from a perspective of health equity. Now, with regards to another question that came forward, Dr. Ko, you did mention, of course, the issues around hate crimes and xenophobia. Are you familiar with any aspects of how DHHS and other agencies within the government, including Department of Justice, FBI, et cetera, are trying to really take record and track of how these hate crimes are impacting the AA Native Hawaiian Pacific Islander community?
So that's another great question, and I can answer in a couple of ways. First of all, again, getting good data on this has been very difficult. And again, I want to thank our colleagues from San Francisco State University, Professor Russell Jung and others. So the data I presented are all the result of their database, but they'll be the first to say that it's incomplete and probably underreported. So when the president signed the the Stop COVID Hate Crimes Act, it was a way of bringing the health professional worlds and public safety closer together, police and law enforcement, to track these hate incidents and crimes more systematically, to get better data, and then to coordinate better action to address those crimes and then prevent them. So there is a plan coming out of that whole effort, and I think we now have more attention to this from Congress than we've ever had before. So in a time where everyone's talking about social determinants and all sectors of society working together, I think the more public health works with public safety and law enforcement on these hate crimes issues in terms of addressing them and preventing them and tracking them, the better off we're going to be.
Dr. Ko, I know in your work as being the Assistant Secretary of Health, you probably visited every state of the union, as well as you mentioned, jurisdictions that either are currently under the United States or historically have been part of the United States. That I'm framing that relative to this question. The population centers and the distribution of Asian Americans, Native Hawaiians, and Pacific Islanders is not homogeneous across the 50 states and the territories. In those states and communities where there's, relatively much smaller percentage of the population is Asian American, Native Hawaiian, Pacific Islanders, vis-a-vis something like California, how would a activist or public health advocate who's really looking after these issues that you touched upon address those in communities to have much fewer Asian American, Native Hawaiian, Pacific Islander faces? In other words, a small community, rural hospital in, let's say, even Montana, Wyoming, et cetera. These much more states have a much smaller percentage of Asian Americans. Are there any recommendations that you would give to these individuals that might be advocating on behalf of our populations?
What a great question. Yeah, and I'm fully aware of this. So there's no doubt that the NHPI community is more populous and perhaps more active in places like California and Hawaii. I'm from Massachusetts, so I'm fully aware that on the East Coast, we perhaps do not have the level of activity that we enjoy on the West Coast. So that's why conferences like this, Dr. Wong, under your leadership, are so important. If we can signal to everybody that we have a national effort here, we support one another. In your community, if you can rally and help the leaders who are raising attention to these issues. Here in Boston, I have a great colleague at University of Massachusetts, for example, Professor Paul Watanabe, who's been at this for 30 or 40 years. He shared a panel with me recently and said he's getting more attention for his work now than he's had in the last 30 years. So that's good. When we see colleagues, for example, at NYU, they've been doing excellent work on Asian American health disparities for a long time. Through the forum, Health Forum, Juliet Choi's organization that has a DC office as well as a California office. In the Midwest with leaders like Dr. Karen Kim at University of Chicago. I think the more we identify such leaders in critical parts of the country and have us work together through a national effort like you are now leading at the National Academy of Medicine, the better off we're all going to be. Because this is not just important for us, it's important for the future of the country, given how fast our population is growing.
Well, with that ending comment, Dr. Ko, it's just been a tremendous hour. Thank you so much. And we certainly look forward to your ongoing leadership in these roles. Thanks again. We're going to now move to our next speaker. And with that, I'm going to introduce another colleague of mine who sits on the roundtable for health equity, and also really a trusted leader that I've come to learn to know over the last several years at the Northwestern University, and that's Dr. Melissa Simon, who's going to moderate our next panel. Dr. Simon.
Thank you so much, Dr. Wong. This is quite amazing. Thank you all so far for these amazing comments and talks. I have a very distinguished honor to moderate a panel with three amazing people and deep scholars in their fields. Dr. Nadia Islam, Dr. Brittany Morey, and Dr. Sherry Daniels. Dr. Islam is an associate professor in the Department of Population Health at the New York University Grossman School of Medicine and the associate director for NYU's Langone's Institute for Excellence in Health Equity. She also co-directs the NYU City Colleges of New York Prevention Research Center and the Community Engagement and Population Health Research Core of NYU's Clinical Translational Sciences Institute. Dr. Islam is a medical sociologist with a doctorate in socio-medical sciences from Columbia University. Second on the panel, and I'm just going to introduce all three panelists first, and then I'll have each of them speak, and then we'll have a few minutes at the end for questions. Second on our panel is Dr. Morey. Dr. Morey is an assistant professor of public health at University of California, Irvine. Dr. Morey's research focuses on how structural inequity shapes racial and ethnic health inequities. Her work also studies how United States immigration policies and anti-immigrant sentiments contribute to health disparities among populations of color. Currently, Dr. Morey is working as a co-investigator on a grant funded by the National Cancer Institute to examine how ethnic enclaves and neighborhood sociocultural institutions affect health outcomes for Asian American and Hispanic women with breast cancer. And third, Dr. Sherry Daniels was born and raised on Maui and is a graduate of the Kamehameha schools and the Kapalama campus. She holds degrees in the field of counseling psychology and has several licensed certifications. She has more than 20 years of experience in social services programs across Hawaii in both the nonprofit and government sectors. Dr. Daniels is actively involved in various community organizations on Maui, including Hawaiian language education, and she joined Papaola Lokahi as executive director in April of 2016. We will begin today with Dr. Islam. And again, there will be time for questions and discussions following the presentations. Dr. Islam?
Great. Thank you so much, Dr. Simon. I'm just going to share my screen. Can everyone see my screen? Yes.
Yes, we can.
Okay, wonderful. Well, thank you so much for that kind introduction again, and really a huge thanks to the National Academy of Sciences, Engineering, and Medicine for the invitation to participate in this inaugural roundtable on the promotion of health equity for Asian Americans, Native Hawaiians, and Pacific Islander communities. I'm really honored to be part of this panel and joined by our distinguished panelists, Dr. Morey and Dr. Daniels. And I'd like to underscore that I really hope that this is a first step in sustained and continual engagement with both Asian American and Native Hawaiian and Pacific Islander communities. My remarks today are going to center our work at the NYU Center for the Study of Asian American Health, which is the first and continues to be the only national research center of excellence funded by the National Institute of Health with a focus on eliminating health disparities in Asian American communities. So I'm really going to center the experiences of Asian American communities today, but I'll also highlight some common data related challenges across Asian Americans and NHPIs. I think today you're going to hear many similar themes, and indeed, I think you may hear some of us repeat the same things. The reality is we've been banging these drums for decades. I don't think it's an understatement to say that as researchers, as community activists, as community members, we're weary, but I think really ever dedicated in our resolve and really ever more aware of the urgency of these issues. So I think my screen stopped sharing. I'm going to share it again. So to get us started, we were asked to speak on this panel about the myth of the model minority. But I'd argue that in setting the context for any discussion of health equity in Asian American communities, we need to discuss not one, but actually two distinct yet mutually reinforcing myths that are applied to our communities. The first is this idea of Asian Americans as a model minority, that we're more educated, harder working, higher income, an idea that was referenced in the media as early as the 1970s that you can see here, and has really been consistently perpetuated over time. Critical to understanding why the model minority exists is that this stereotype is rooted in anti-Blackness. The idea was developed by a conservative majority to oppose the Black Power movement of the 1960s in the knowledge that America is fundamentally a racist society structured to keep minorities in subordinate positions. The model minority myth then allows for the narrative that individual underperformance is the reason for racial inequality, and correspondingly, the success of Asian Americans is used to deny the existence of institutional racism. And we see this really across time, we see it's rooted in as early another concept that really works in parallel to the model minority myth is the idea of Asian Americans as a perpetual foreigner, that we don't belong here, that we are somehow other. And the origins of this concept date back to the Chinese Exclusion Act and have been applied across Asian American communities through, we see the internment of Japanese Americans, as well as targeting of Muslim and South Asian communities post 9/11 and through Trump's Muslim ban. So this concept is really that the idea that Asian
Dr.
Americans—
Islam,
Yes.
I'm sorry to interrupt. Are you advancing your slides?
I am.
Okay, they're not showing.
They're not showing. Let's try it again. So sorry. And how about now?
Okay, we can see the first slide. That's the cover slide. Can you
Okay.
advance it one more?
Are you seeing me advance?
No. Maybe if you go back to that other view, you'll at least be able to, we'll at least be able to see the slide. It just won't be it won't be centered, obviously.
How about right
Yeah,
now?
just go that way. That's fine. That's fine.
All right, I'll try to make it a little bit bigger.
That's good.
Yep. Okay. So I was speaking about the idea of Asian Americans as a perpetual foreigner, showing some historical examples. But I think what's important to highlight is that this concept is really applied across the life course and really regardless of immigration status. So this is an image I like to show to demonstrate. This is media coverage of the 2015 Scripps Spelling Bee, noting to South Asian American young children who were co-champions. And then on the right, you see the corresponding social media response, really decrying the lack of quote unquote real American winners. I'm not sure if you can see some of the text because of the slide, but there is some, really kind of racist vitriol against, kind of the idea of real Americans not winning the spelling bee. So the idea of the perpetual foreigner has been reinforced during the pandemic with references to COVID-19 as the Wuhan or Chinese virus, resulting in xenophobia towards individuals of Asian American descent, as highlighted by Dr. Ko, an increase in hate crimes, and the tragic massacre of 6 Asian women in Atlanta on March 15th. Again, as highlighted by our earlier speaker, upwards of 2 million Asian American adults have reported experiencing anti-Asian hate since the onset of COVID-19, including 1 in 8 Asian American adults in 2020 and 1 in 10 in the first quarter of 2021. So this context, the Asians at once a model minority and the perpetual foreigner, is important because it is both driven by and results in the lack of data equity in Asian American and NHPI communities. Data aggregation within and across AA and NHPI populations, which, as we know, lumps together more than 30 unique subgroups, renders our communities invisible. A recent American Medical Association Center for Health Equity report on AAPI communities noted, what is measured is what is valued, what is undercounted tends to be counted out. And I think this perfectly encapsulates the experience we face as Asian Americans. And I'll walk us through some illustrative examples. So let's start with educational attainment, which in many ways is a central dimension of the model minority myth for Asian Americans, that we as a group are better educated than everybody else. So aggregated data does indeed show that Asian Americans have higher rates of educational attainment than other groups and the national average. But disaggregated data demonstrates a very different picture, calling attention to differences across Asian American as well as Native Hawaiian and Pacific Islander communities. When we look at poverty levels in aggregate, we see a similar thing, that in aggregate, it looks like Asian Americans have much lower poverty levels compared to other groups. But then again, when we look at it in disaggregate, we see a very similar picture to education. And this is important because education and poverty are really key determinants of health driving disparities. It's important to note too, and this speaks to one of the earlier questions by the audience, the geographic diversity and spread of Asian American communities. About 5% of the population nationally is comprised of Asian Americans, but this community is as large as 15% in places like New York City, where we conduct our work. And the demographic profile varies with other locations. So here you can see this is data from New York City from the Office of the Mayor. Even when looking at aggregated data, so this doesn't even account for disaggregation, New York City Asian Americans are a low income group, one of the lowest income groups. Another critical factor impacting all dimensions of health for Asian Americans is language access and proficiency. Both Asian Americans as a whole and particular Asian American subgroups have high rates of limited English proficiency, about 30% of Asian Americans as a whole, but up to as high as 78% in some communities. So why does all of this matter? Really put simply, invisibility is killing our communities, and nowhere is this better illustrated than in the pandemic. National efforts, put plainly, have left Asian Americans out. And we've seen this from the NIH, from the early part of the RADx program, and very few Asian American projects being funded, to even early reports by NASAM, which really left Asian Americans out. This may be driven by an undercount of Asian Americans in COVID data that is reported at the city, state, and national level. Studies have demonstrated that Asian Americans and Hispanics are more likely to be classified as other or missing in administrative data. And further, sociological literature has demonstrated that perceptions of only East Asians counting as Asian Americans may drive underrepresentation in data. The invisibility of Asian Americans has manifested in several ways when it comes to the pandemic. This is a recent analysis conducted by a journalist that documented the number of articles referencing Asian American, Latinx, and Blacks and unemployment due to the pandemic, and found a much lower number of articles referencing Asian Americans relative to other groups. And this is despite what we know and have learned through community reports and even through analysis, really demonstrating that in particular Asian American low-wage essential workers, as well as Asian American small business owners, were disproportionately impacted by pandemic closures. We see similar patterns when it comes to academic research. And what's disheartening is that we are left out, are invisible, despite at this point fairly ample evidence that COVID is disproportionately impacting Asian American communities compared to white populations. This is an analysis by Chu and colleagues of National Health Statistics death certificate data, which found a disproportionate burden of COVID among Latinx and Black communities, but also for Asian American and NHPI communities. A number of other studies have demonstrated similar findings, and thank you to Dr. Ko for highlighting some of those. I'll highlight another. A systematic review of 18 million patients across 50 published studies found Black and Asian individuals at higher risk for COVID-19 infection compared to white individuals. When we examine by subgroup, an even clearer picture emerges. This analysis was led by Rupa Marcello and her team in collaboration with our center at NYU and examined data from 85,000 patients in New York City's public hospital system from the period when New York City was the epicenter of the pandemic. Our team applied an innovative surname methodology to better identify patients by subgroup ethnicity. And when we did that, we found that South Asian patients had high rates of COVID positivity, second only to Latinx patients, as well as high rates of hospitalization, second only to Black patients. We also found that Chinese patients have the highest mortality from COVID after controlling for age and gender. Data quality issues cannot be overstated. As illustrated here, race and ethnicity data is missing at the national as well as local levels. This is missingness of race and ethnicity data in regards to vaccine. While the slide that I'm presenting here is from March of this year, if I updated the slide with our most recent data, the level of missingness has really not been improved very much, maybe by about 5 to 10%. So it's important to underscore that one size does not fit all when it comes to COVID solutions for Asian American communities. Our center has really synthesized available evidence to look at a number of risk factors that are driving COVID. And while risk factors vary, there are some commonalities in terms of concentration of Asian Americans in multi-generational housing, the economic implications of the closures of businesses impacting several Asian American subgroups, and then anti-Asian hate and xenophobia and the consequences across the pandemic spectrum, resulting in delays in testing, delays in seeking care, as well as delays in vaccination. So I'm going to end with some key recommendations. First, it is really critical that all states collect, analyze, and report disaggregated data separately for Asian Americans and Native Hawaiians and Pacific Islanders and for Asian American subgroups. As I highlighted at the beginning, this is not new. There's plenty of precedent by current OMB standards that were developed under Dr. Koh's leadership. Asian American and NHPI data should be disaggregated, which is not happening in a number of states. And we should also be separating Asian Americans and NHPIs as really a minimum standard. I hope I've underscored that data disaggregation and its rootedness in the model minority myth and the idea of Asian Americans as a perpetual foreigner really constitutes an emergency situation for our communities. We have to demand that disaggregation can take place and that there's potential to do this through an emergency declaration or other mechanisms. Second, we really must prioritize language access for Asian American and NHPI communities across health disparity efforts, across COVID-19 efforts. Language access goes beyond translation of materials, which also needs to happen accurately and with community review. Online and phone-based services must be available in multiple languages, and interpreter services for on-site vaccinations and testing in the COVID context, as well as for other health disparity domains. I think throughout the pandemic, we've seen the tremendous ingenuity of our community in coming together to ensure and demand that services, that messages are translated, that they're culturally tailored. I think throughout today and on Thursday, you'll see many examples of this. Our center at NYU has been leading many of these efforts. But what I want to emphasize is that the community advocates, community-based organizations, community health workers, other community leaders have been doing this, but are stretched to capacity. So it's really crucial that more resources are put towards these efforts. And finally, and I feel like this is maybe my most important point, and I'd love to have a discussion on this with the panelists. Decision makers, and this means policymakers, it means funders, it means scientists like myself, scholars, have to interrogate their own implicit and explicit biases against Asian American and NHPI communities. The data and the stories are there, and we have the strategies to analyze them. At this point, the evidence is there as well. What we need to do is to read the science. We need to learn from our narratives, particularly our community narratives. We need to fund the work and protect our communities. I'll end with an example. You know, like many of us, I often am asked to give talks about the model minority and the implications of the model minority. I often come armed with much of the data that I showed here today, as well as other examples about why it's so important to disaggregate by subgroup. And when we do that, we can see that there's tremendous variation in this community, that there are tremendous needs that are not being met. And I gave a talk like this at a conference a few years ago. And a policymaker came to me afterwards and said, you know, that was such a compelling talk. I really understood what you were saying. But you know what's interesting is my husband is a teacher and his best students are the Chinese and Vietnamese students in his class. And so I think it just goes to show that, you know, we have to constantly really interrogate some of these implicit and indeed explicit biases that are leveraged against AA and HPI communities, even when data is provided. So I'm going to end with that. I'd like to acknowledge the many collaborators in my work, including all of the faculty, staff, and partners at the NYU Center for the Study of Asian American Health. I'd like to especially thank Dr. Stella Yi, who has been leading much of this work at our center through the Applied Research and Evaluation Unit, Dr. Lan Duan, who is a postdoc, and several of members of my team who assisted in putting together the presentation today. Thank you, and sorry about the technical difficulties, but I look forward to our discussion.
Thank you so much, Dr. Islam. Next, Dr. Brittany Morey, please, it's your turn.
Hello, everyone. It's wonderful to be here with you today. I'm very honored and humbled to be here. Before I get started, I just want to recognize that here where I'm speaking from at the UC Irvine campus is located on the ancestral homelands of the Hashimin and Tongva peoples, the stewards of these lands. I'd also just like to give the disclaimer that the opinions that I'm going to be expressing in this presentation are solely my own. They don't necessarily represent those of my institution or my funders. So I think, as Dr. Islam was saying, you might be hearing very similar themes across the various talks over the next couple of days. But I just wanted to kind of zoom out and give a little bit more of a bird's eye view of the historical and political context that led us to this point. At the beginning of the pandemic, the initial disaggregated data that we had showed that Pacific Islanders were being indeed hit hard by the coronavirus pandemic. We also saw that even though there was very little disaggregated data for Asian Americans, there were some data showing that Filipino Americans especially were dying of COVID-19 at an alarming rate, which could possibly be linked to a large number, especially of foreign-born Filipinos working in nursing and in healthcare. And of course, we also saw this rise in anti-Asian hate. And I just want us to understand that these things did not come from nowhere, and they're also not unrelated. So it's so important for us to understand the historical and political forces that led us to this point, so that we can better then understand how we can move forward to recover and to achieve healing and well-being for our communities. As the great Dr. Cornel West says, you can't move forward until you look back. I just want to show the social ecological model of Asian American and NHPI health inequities to show us that individuals, of course, are not islands. And in order to understand individual health, we need to see the relationships between these larger concentric circles of influence, such that individuals are located within communities. And we know that communities and neighborhoods have had different levels of spread of COVID-19 and also different levels of resources given to combat the virus. But these community factors are also nested within a larger policy environment. And by policy, I mean policy quite broadly. Not only health policy, which determines access to healthcare and health resources and prevention, but also social policies, including immigration policy, which determines who is allowed to come and remain in the United States and the types of resources and supports that they have while here in the United States. Now, policies don't need to be just laws and legislation, but also within institutions, including public health institutions at the state and local level that have different policies regarding the reporting and collecting of health data, such that by not disaggregating AA and NHPI data, we then ignore the disparities or can't see the disparities, which leads to a lack of resources for those communities that need it, whereas other policies of disaggregating data have led to more and greater resources. Now, these policies are considered, they're passed, they're proposed in a larger societal context. So we need to talk about the societal context, specifically factors of racism and xenophobia and how they've affected our communities. Now, you might also be hearing some of this history, but I know we don't have time to go in through all of the history of Asian Americans or NHPIs in this talk, but I just wanted to point out some key facts throughout history that affect us today and affect us moving forward and inform how we move forward. Of course, the first Asian immigrants in the early 1800s were mainly from places such as China and the Philippines. They were contract laborers, and they suffered from poor working conditions, lynchings, murder, blatant discrimination. And of course, with the increase of Asian immigrants, became an increase of fear, especially among white Americans. Asian immigrants were blamed for depressing wages, for taking jobs away from quote unquote ordinary Americans, and for a variety of social ills, which eventually led to the Page Act and the Chinese Exclusion Act. These were the first laws in the United States specifically preventing the naturalization of a group based on their national origin, specifically singling out Chinese people, and also restricted immigration from China. This led to the opening of the door for other restrictive immigration policies that restricted immigration from other Asian countries as well. Eventually, we saw that, of course, Asian immigration continued to the United States, but even US-born Asian Americans can be victims of xenophobia and racism. When Pearl Harbor happened in 1941 and Japan bombed Hawaii, we saw that the United States passed Executive Order 9066, which interned all Japanese Americans, even though this was shown to be improper and a form of structural and institutionalized racism, because there was no evidence that Japanese Americans posed any threat to national security. I want to fast forward to the Civil Rights Movement of 1965, where a lot of important things happened, including the coining of this term Asian American. Now, Asian American was not a term that was used widely before 1965, but it was used in order to bring together all of these various Asian groups and from different nationalities in order to advocate for civil rights and social justice. Now, while this term Asian American came to be in the 1960s, this is also when we saw the proliferation of the model minority myth, as Dr. Islam was saying. And it's important to note that this model minority myth was not only used to gloss over the continued struggles of Asian Americans and the continued discrimination that Asian Americans were facing at the time and continue to face, but it also served to drive a wedge between Asian Americans and other communities of color, namely Black Americans, in an effort to try to dilute the civil rights movement and to proliferate anti-Black racism. Now, in 1965, we also saw passage of Immigration and Nationality Act, which is the last major form of legislation that dictates our immigration policies largely today as well. Fast forward to the Refugee Act of 1980s, we saw the door opening for refugees, including those from Cambodia and Vietnam, who have been the victims in US wars. And we've also seen major hate crimes occur in our recent past. The 1982 infamous killing of Vincent Chin, a Chinese American man who was killed by two disgruntled auto workers who blamed the Japanese for losing their jobs. And the more recent 2017 killing of Srinivas Kuchibhotla, who was killed by a man screaming, "Get out of my country." So I provide all of this history and context so that we can understand better how policy and historical context help to shape how Asian Americans arrive in the United States, the level of resources that they have, and how Asian Americans, even those who are US born, experience racism and xenophobia. And it's important to know this history, to know that how policies impact how people of different national origins fall into these different immigrant visa categories and statuses. And it depends on whether people have come as refugees or asylees, whether they come to work, whether they're undocumented. That determines the levels of resources that they have and the great diversity that we see in socioeconomic status that Dr. Islam showed earlier. So this status impacts health inequities because we know that immigration status overlaps with socioeconomic status, which is a fundamental cause of disease. We also cannot ignore the 1.7 million undocumented Asians in the United States. This is the fastest growing group of undocumented persons in the US who have limited access to health resources and also have been living in fear of deportation and detention in an anti-immigrant environment. Legal immigrants as well have restrictions from being able to access federal benefits, including a 5-year waiting period before they can access resources such as Medicaid. But even immigrants who become legalized and who can qualify for these benefits often do not take them for fear of public charge, fear that any way that they are seen as dependent on the US government might jeopardize their application to become naturalized citizens. And of course, anti-immigrant sentiments and xenophobia has spillover effects even on Asian Americans who are US born through assumed foreignness and increased discrimination and stress. This status affects COVID-19 health inequities through the likelihood of many Asian American groups being essential workers, including healthcare workers in the example of Filipinx nurses. Many Asian Americans are small business owners that have suffered during the pandemic. And of course, many families have been fearing anti-Asian hate and violence, especially against our elderly members. At the same time, our most vulnerable groups, those who have low socioeconomic status, have had little access to linguistically and culturally concordant health resources. Now, I want to pivot a little bit and talk about how the model minority myth in the context of Native Hawaiian and Pacific Islander health disparities. You've seen this map before, but I want to just point out some of the important differences in context when NHPIs are often lumped together with Asian Americans, but actually come from a very different places, nationalities, and also have very different relationships with the United States. Let's take, for example, Hawaii, which of course, people in Hawaii are US citizens, but Native Hawaiians, because of their long history of colonization leading to the overthrow of the Hawaiian monarchy, means that Native Hawaiians living in Hawaii today experience some of the highest poverty rates. We also see that within the Pacific Islands, there are also US territories. For example, those born on American Samoa are considered US nationals, while those who are born on Guam are considered US born citizens. We also have the Pacific Islands that fall under compacts of free association. These are COFA. And these are the Federated States of Micronesia, the Marshall Islands, and Palau. These COFA associations allow these citizens to freely live and travel into the United States, and many have done so. And many COFA migrants in the United States work in industries such as meat processing. And so we've seen during the COVID-19 pandemic that Marshallese have been highly impacted through these outbreaks that have occurred at these meat processing plants. Now, we also see that many COFA migrants have experienced continued detrimental health effects because in exchange for being able to freely migrate to the United States and live in the United States, they give the United States continued access, military access to their islands. And in the 50s and 60s, the US conducted its nuclear tests here in Micronesia. And so many COFA people from these nations experienced the detrimental effects of this nuclear testing. While between 1996 and the year 2020, just this past year, they had been stripped of federal Medicaid benefits and could not qualify for those benefits until this was reversed just in this past year. Of course, people from the other islands, including Tonga and Fiji, the Solomon Islands, and the others, are considered immigrants when they come to the United States. So I give this brief overview so that we can understand how colonization, how militarization has helped to shape the social determinants of health that we see today, that has helped to shape, therefore, the COVID-19 disparities that we've seen, such that we've seen higher rates of poverty, lower levels of insurance, of course, higher rates of neighborhood poverty and environmental pollution. NHPIs are also highly communal, which is a very beautiful thing, but this also means that they are more likely to live in intergenerational homes And higher levels of poverty and dense housing means that they're more likely to live in more crowded living conditions. They're more overrepresented in essential workforce and at-risk jobs, including food preparation and the military, and higher prevalence of pre-existing chronic conditions that have led to higher rates of COVID-19 mortality. Now, the framework that I have found that best contextualizes all of this history and policy is that of structural racism. And structural racism is defined by Bailey as the ways in which societies foster racial discrimination through systems, for example, through housing, education, wealth, healthcare, immigration policy, and incarceration, reflected in history, culture, and institutions. So when we see these disparities, these hate crimes, they really are just one symptom, the tip of the iceberg, when in order to address long-term health inequities, we need to address what's under the surface and the structures and the policies which uphold structural racism and which uphold health disparities. So it's easy to hear all of this and to learn all of this and to want to maybe despair to see how long, all of these inequities have been happening. But I want to stress that not all is lost, that there are actionable steps that we can take today to start to chip away and undo these structural factors. So here are some key recommendations. First of all, and I'm sure many of others are going to repeat this, we must have disaggregated health and demographic data for AA and NHPI subgroups. We need to have more multi-level interventions to address issues at the local, county, state, and national level. We can increase resources to AA and NHPI serving community-based organizations. And we can also further bolster community capacity through investments in youth leadership development. And last but not least, I think there's a lot we can do to combat the prevalent model minority myth, which was originally intended to drive a wedge between various communities of color. And instead, we can strengthen and build transformational coalitions across racial and ethnic groups in order to address common issues that affect all communities of color. Here are the references that I used in this presentation. And thank you very much for listening. I look forward to your questions.
Thank you so much, Dr. Morey. Next is Dr. Sherry-Ann Daniels. It's your turn. Thank you so much.
Velina mai kako, everyone. I really want to extend a huge mahalo to my co-presenters here, Dr. Islam and Dr. Morey, and then they have covered a lot of things that, we're kind of preaching to the choir a little bit here. I think many people, it resonates what they've talked about. This isn't, I think we've said it numerous times, this isn't new information. I kind of wanted to take a different approach to as we talk about this model minority component. And I wanted to talk a little bit about the historical overview, really from a Native Hawaiian realities perspective. So before I start off, I wanted to acknowledge na makua, na kupuna, na ohana, and na lahui, that as a Native Hawaiian, we not only look at where we stand today, but where we've come from and the generations in front of us that we create pathways for. And so my onehanau, my birthplace is Maui, out in the Pacific. And so I wanted to acknowledge that today. I think we all can recognize the value of narratives. COVID-19 really has put a spotlight on how, as our communities, we look at ourselves, we re-examine our truth, and we are much more activated in, I think, reaffirming, reigniting the narratives of our community. Ika olelo no ke ola, ika olelo no ka make. Basically stands, it's a olelo no ea, or a proverb, that in language is life, and in language there is death. And that is not just figuratively, but when we talk about our communities and the value that our communities bring, we have to be very thoughtful in how we engage, but also as we speak for. I think we oftentimes have a belief that we're helping everybody along, but we'll have our narrative, and it's being really clear of where our lanes are so that we truly can uplift communities. I think we've heard in the other talks from the other presenters really about data disaggregation, especially around subsets. And I want to be really clear that for Native Hawaiians, we are our set. There isn't any other subpopulations or subsets in our community or in our two-letter word. It is us. And so I think, when we look at data disaggregation, we want to be really clear that for Native Hawaiians, we want to make sure we're collecting data for our Hawaiians in Hawaii, but also along the continent, as there are Hawaiians that reside in all 50 states. And so just a little historical perspective, like many communities and like many of others in Asian American, as well as our Pacific Islander cousins, we came from a people that were very healthy. We were not sick and disparate. That when we look prior to contact, our communities were thriving. We had low incidences of disease. We were free of epidemic or other contagious pestilence. Our skeletal remains basically showed some dental cavities. That when we look at the logs of the sailors, that they talked about the resiliency of our people when they visited our islands. That we come from a legacy of excellence. When we look at in our community being able to transverse the globe by just using the stars and the celestial guidance, that we know is there. We had Hokulea re-transverse the earth a few years ago in their Malama Honua. We also see through feather work and through sports and other religious practices, really this belief of excellence that we are born from. We also see that in terms of natural resource management, our people were very ingenious through their engineering work. They were masons, they were conservationists. We really used things when we needed it. We allowed time for the replenishment of our resources. And so things like that really showed and demonstrate to us that, at the core of who we are, we're not about being disparate. We're about resiliency. And so what happened, right? Basically the impacts of colonization. And kind of the new word here in Hawaii is not just decolonizing or colonization, but really around occupying us, that Native Hawaiians were occupied. Our kingdom was illegally overthrown, and we know that because the government acknowledged it in the apology bill. But we know that the impacts of that being occupied has led to foreign disease, the introduction of foreign disease, our breakdown of our religious system and those accompanying taboos, I can't even talk today, I apologize, the dispossession of land, as well as the foreign system of government, and really the introduction of a cash-based system of economy, suppression of language, traditions, customs, and values. Those things, you remove language, you remove a culture. And that was what the Olelo No'eau that we started off with. So when we look at the data, the dissemination of Hawaiians really from contact all the way to about 2000, we see this huge decrease of Native Hawaiians. We do know that in the census between 2000 and 2010, that we saw an uptick of the number of Native Hawaiians that are checking off being Native Hawaiian on that census box. We are looking at how 2020 rolls out for us. It does look like there's more. However, many Native Hawaiians are multi-ethnic. So there's more than 2 or 3. It isn't uncommon for many Native Hawaiians to be 5 or more. But again, when you check the box on the census, how is that weighted amongst other communities? We know that through work of our ali'i, that they recognized over a century ago the impacts of the foreigners coming onto our soil, and really trying to work at how that they can impact the trajectory of their people, from looking at health to education to our kupuna, our elders, housing, and even civic engagement. And fast forward because between the time of 1893 to about 1970, our Native Hawaiians really suffered through loss of language, lands, economics, even from when we look at natural resources where we had non-natives diverting water to our food sources, to our water systems, which all had impacts on fish, on shrimp, and those things. And that was all for the sugar industry, pineapple industry, which then also included the tourism industry. So back in the early 80s, a study was done, a minority report, which is volume 1. And when the commission reviewed volume 1, it really did not show that Native Hawaiians had any impact in terms of health disparities. And one of the commissioners had asked that there be a specific Native Hawaiian study done. And so volume 2 came out, and it's called the Minority Report. And that's where they started to recognize and document the severe health, economic, and educational problems that affect Native Hawaiians. So similar to Asian Americans and Pacific Islanders, Native Hawaiians had the highest number of individuals incarcerated in youth, in foster programming, in substance use, in a lot of the socioeconomic challenges. But we were struggling in those positive areas of educational attainment, economic stability. And so in 1983, this minority report came out. And that actually led to the Aola Mau study, which started in 1985 and concluded in 1998. And that brought together, through Dr. Kekuni Blaisdell's guidance, over 21 researchers and agencies. And they worked on 6 separate volumes looking at Native Hawaiians' physical, mental, and spiritual health status. And as we know today, social determinants of health, right? That in working with an individual or families or communities, that it's the whole piece. It's all of those things from education to housing to health that we need to address. But not only that, for Native Hawaiians and other minority communities, it's also looking at the impact that spirituality has in the everyday lives of our people. And so what that report found, that in comparison to the overall US population at the time, so this is 1985, that the death rate for all Hawaiians was 34% higher than the US average. That has actually gone down slightly today, but we also know that the average life expectancy for Native Hawaiian males is 72. So already we are behind the ball in how we can make sure our communities remain healthy. And back in 1985, those numbers in red is what we saw in Native Hawaiians. And that for diabetes, that is not an incorrect number. It is 222% higher. And again, this is in 1985. There has been work to decrease that, but that's still very high. And so how do we move forward? What does that look like? And I think starting off with understanding our narrative and looking at it from a strengths perspective, which I know we do anyway in the work we do as in our communities, is finding the strengths that we can come together. And I think it was mentioned during COVID, we saw communities come together, work hard, figure it out, even with limited resources, that we have that. That's really something of strength for our community and our resilience factor. So pupukahi I holomua, how do we move forward unified? So what Aola Mau allowed for was the recognition by the federal government through the work of our senators at the time, Daniel Inouye as well as Daniel Akaka, to introduce the Native Hawaiian Health Care Act. And that was really one attempt to start to move the dial around Native Hawaiian health. And that created Papaololokahi, which is the Native Hawaiian Health Board. And so we are one of 3 Native Hawaiian acts, codified federal law. We oversee health. There's a housing component as well as education. And our housing component is actually tied to our Hawaiian Homes Commission Act of 1921, and in which that act and for Dr. Mori to add to your list, that was actually as good as it is, it wasn't the best outcome for Native Hawaiians because they actually instituted a quantum level, a blood quantum, in terms of being able to access land as a Native Hawaiian. You have to be what they label as small n. So you have to have 50% or more, you have to be 50% or more Hawaiian. And so when we read the articles back then, the government actually wanted to make it 100% blood quantum. And so at the time, Jonah Kuhio Kalaniana Ole, who was our delegate, actually had to really negotiate that down to 50%, which at the time was considered a win. And so Papa'ololokahi oversees the Native Hawaiian health care systems that are located across Hawaii, but we also partner with colleagues and organizations, CBOs, across the United States to deliver services to Native Hawaiians. We also oversee the Native Hawaiian Health Scholarship Program that funds Native Hawaiian medical professionals with a scholar payback in terms of service obligation in high rural communities here in Hawaii. We also oversee traditional practices as well as any legislation and advocacy efforts around Native Hawaiian health. You know, we talk about what COVID has done in terms of culturally targeted materials, PSAs, both linguistically, but also visually. And these are things that we've been doing for 20 plus years. So I think it's really exciting that things are getting caught up to our communities where they're seeing the value of culturally targeted materials. But again, these were things that many of us were doing over the years, maybe not being funded for, but doing it because that's the right thing to do for our communities. I also wanted to just briefly share, we have about close to 600,000 Native Hawaiians now with the 2020 census, with a lot of them, a growing number residing on the continental US. And then for recommendations, really, I'm gonna just, yes, kako'o or mirror what both Dr. Islam and Dr. Mori talked about, definitely the disaggregated data, but also beyond that, how do we enforce that and provide accountability to that OMB 15 that's already on record? I also wanna point out that when we talk about limited English proficiency, again, it's English, you know, I don't know if limited is, you know, one of resiliency or not, but it makes our communities feel less than. And for Native Hawaiians, even more so, because for us, it's a reverse in terms of accessibility. Our community will speak English, but many of our communities speak Olelo Hawaii, which in Hawaii is our second language. And so it doesn't quite fit the criteria of limited English because our people speak English, but we should have the right to access our language and have our language used to access health and other services. So I think when we look at some of these pieces moving forward, one of the recommendations is learn about our communities. No two are alike. So feel, hear, and see what we are. I think we all have the best of intentions to uplift each other, but if we don't know really and understand what lanes we reside in, we actually could be doing more harm than good for our communities and for our neighbors. Talk with and not about. So kind of like research, right? We're always looking for, is it been vetted? Is there multiple trusted sources? Ask those questions. I think there is always more than one school of learning. And so if you're you know, going to the same usuals, it might be smart to reach out and ask and find other sources of knowledge and see where those variances lie. And then finally, if not us, then who? Come to us. I think there's more than enough Native Hawaiians out there in various fields that can talk to, but also link to others so that we are the ones driving the bus. I think we all want that in the end. So again, mahalo for inviting me today, and I'll turn it back over to Dr. Simon.
Thank you. Thank you so much. That was amazing, all three of you. We have time for maybe 2 questions before I transition to the next panel. So One question that is in the chat is, why are diabetes and other chronic conditions so much higher in Native Hawaiian, Pacific Islander, and other Asian populations? Is this linked to poverty level and lack of access to healthcare?
I'll take a quick stab at it and I'll turn it over. But for Native Hawaiians, what the study found was that when most Native Hawaiians did not go and do preventive work. They didn't, there is this really a cultural belief about when you go to the doctor, you often go and you die. You go to a hospital and you die. So culturally, there was this already undercurrent of belief in our communities. But also we found that many Native Hawaiians were not using preventive measures. We weren't doing, the early detection of breast cancer. We also, going to doctors, they don't look like us, they don't talk like us. And so when we're talking about spirituality, when we're talking about using traditional practices, many Native Hawaiians, that became really uncomfortable because most of the doctors were not Native Hawaiian. And so you already have this kind of barrier happening. And then on top of that, you put, economics plays a role when it's cheaper to buy canned foods. Similar to down in the US API, right? Using Spam, Vienna sausage, corned beef, those things that can last longer. That's what you're using. There is not a lot of fresh fruits and vegetables. A lot of our supplies are shipped in. So the cost of fresh things are a lot higher. So all of those factors play a role in, and also what we're putting in our body. We know that aipono, or the things that our kupuna or our ancestors ate, we weren't eating. So all of that in the metabolizing of our body all have played a role in that. And so hard to kind of correct an action like 2-3 generations to try to fix it now. So I think those are some of the barriers.
Thank you. There is one more question in the chat as well. Have Native Hawaiians also been targeted by COVID-related hate crimes?
Not in particular. We saw it more with Pacific Islanders, a lot of the Micronesian population, and those smaller communities. And I think a lot of it is lack of understanding, especially when we have the COFA underlinement, right? It's just sees as, it's just often seen. And I think Dr. Mori talked about it, communities feel, or society feels that they're taking from and not adding to, which is just a misnomer. And so how do we develop that education?
Any final thoughts before I transition us to break?
I think I just want to, in response to the first question on diabetes, I want to, I think, amplify one of Dr. Mori's recommendations. Diabetes, like most other chronic conditions, as well as health disparities, are really, it's multidimensional in nature. And so I think, the answer to that question is that it's not just one thing. There are certainly individual level behavioral risk factors, but there's also systemic and structural racism within the healthcare system that's been very exclusionary for Asian American as well as Native Hawaiian and Pacific Islander communities. I think that there's not enough programming and efforts that are really culturally and linguistically tailored in the ways that, can reach our communities. And then I definitely appreciate Dr. Daniel's historical perspective. Our communities did not always have diabetes, and that's really a reflection of historical changes in immigration, acculturation, and the process of adapting to a very stressful lifestyle in the new country for Asian American immigrants in particular.
Thank you very much. Again, Doctors Islam, Mori, and Daniels, thank you so much for your participation in this panel today. It's been amazing. Thank you.
Hi, this is Ernie Moy, and I think I'm supposed to bring everyone back together to start our second panel. I'm Ernie Moy with Veterans Health Administration Office of Health Equity, and it's my pleasure and honor to moderate our second panel today. Our second panel is entitled The Conundrum of Data and Data Aggregation. We'll have three speakers now. First will be Dr. Karthik Ramakrishnan. Dr. Ramakrishnan is Professor of Public Policy at the University of California, Riverside, and serves as the Executive Director of California 100, a transformative statewide initiative focused on building a shared vision and strategy for California's next century that is innovative, sustainable, and equitable. Dr. Ramakrishnan also founded the Center for Social Innovation at UC Riverside and AAPI Data, a national publisher of demographic data and policy research on Asian Americans and Pacific Islanders. He holds a BA in International Relations from Brown University and a PhD in politics from Princeton. Our second speaker will be Ms. Carla Thomas. Ms. Thomas is the Policy Director and founder of the Native Hawaiian and Pacific Islander Data Policy Lab. Prior to joining the UCLA Center for Health Policy Research, Ms. Thomas worked with Pacific Islander-based organizations in the Inland Empire to advocate for disaggregated Native Hawaiian Pacific Islander COVID-19 data, leading to collaborations with local departments of public health in an effort to address the disproportionate impact of the virus on Pacific Islander communities. Ms. Thomas has co-led COVID-19 response projects contracted by the Riverside County Department of Public Health that provided Native Hawaiian and Pacific Islanders and other under-resourced communities with access to culturally and linguistically relevant services. And the final speaker will be Dr. Shin-Chi Dong. Dr. Dong is director of the Institute for Healthcare Policy and Aging Research at Rutgers University in New Brunswick, and the inaugural Henry Rutgers Distinguished Professor of Population Health Sciences. Dr. Dong has led multiple longitudinal epidemiological studies, including the New Jersey Population Health Cohort Study, a population-based cohort of 10,000 New Jersey persons with emphasis on 8 different immigrant groups, and the PINE study of 3,300 Chinese older adults to quantify relationships among trauma, resilience, and health outcomes. He also served as a senior advisor to the Department of Health and Human Services under the Obama administration. We'll begin first with Dr. Ramakrishnan. Dr. Ramakrishnan.
Thank you so much. And hi, everyone. Really honored to be here with you all and to give an overview on some key contours and aspects of Asian American and Native Hawaiian and Pacific Islander communities. I do have some slides that I'll be sharing with you, but first, just to provide some high-level framing on our communities. I can say our communities and not these communities because I identify as Asian American, I identify as Indian American, many other nested and related identities. When people think about Asian Americans, Native Hawaiians and Pacific Islanders, or in the acronym of Nhpis or AAPIs, often there is this consolidation and conflation that takes place, and it's important to think through the context in which it makes sense to think about our populations, these populations as AAPIs, as Asian Americans and Pacific Islanders separately, as separate racial groups, and then thinking about detailed origins within each of these categories. Put most simply, people might ask, when you talk about AAPIs, are we talking about one group, 2 groups, or many groups? And the answer is that it depends on the context, the kinds of analysis that we're doing, the problems that we're trying to solve. So when we talk about APIs as one, historically, there has been solidarity between Asian Americans and Pacific Islanders. And by the way, among Pacific Islanders, if you look at the multiracial Pacific Islander population, about half of them are identify as Asian American and Pacific Islander. So that's part of what makes sense in terms of treating this as one group. At the same time, since 2000, the Census Bureau and US federal agencies have been treating Native Hawaiian and other Pacific Islanders as a separate racial group. That is following guidance from the Federal Office of Management and Budget and extensive community and stakeholder engagement, where it was apparent that Pacific Islanders, given their distinctive history and given their solidarity as a distinct set of peoples as opposed to Asian Americans, it made sense to treat them as a separate racial group. So to that question, are AAPIs one, two, or many? If you think in terms of race, absolutely they are two distinct and separate groups. And you'll have data collections from the US Census Bureau and other federal agencies that do treat them as different for the collection, analysis, and dissemination of that data. But it's also many. So within the Asian category, you see so much diversity, and I will show a few slides in a minute here, both within the Asian category as well as the Pacific Islander category. You have significant variation, and it's important to pay attention to this variation. I am the founder and co-director of API Data, and we started in 2013 to help journalists, government agencies, community organizations, and many other stakeholders who are not specialists in Asian American and Native Hawaiian and Pacific Islander populations to have a better sense of some of the key contours of this group. So let me just share with you some slides, and I'm hopefully getting my hopefully you're able to see what I have here. So if you look at educational attainment, for example, you see tremendous variation on an indicator like bachelor's degree or higher attainment, where you generally have refugee populations at the low end of that scale, and groups like Indian Americans at the high end of that scale. You also see variation within Native Hawaiians and Pacific Islanders, where you'll see variation in educational attainment. You also see significant variation in terms of limited English proficiency. In fact, for some Asian American groups, their level of limited English proficiency are much higher than it is for Latinos. Overall, for Asian Americans as a racial group, their level of limited English proficiency is on par with the Latino, Latina, or Latinx population in the United States. So those are some reasons why it's important to pay attention to differences within the community. Now, I also want to say a bit about how our communities have been impacted by COVID, and what that means, both in terms of health outcomes as well as experiences with discrimination and hate. So I'll go back to screen sharing in a second here. So when it came to COVID-19, there's been a significant level of concern, not only in terms of the health impact of COVID-19, and I believe Carla Thomas will be speaking a bit about, especially as it impacted Pacific Islander communities in the United States, but also the uptick that we saw with respect to hate incidents and hate crimes targeting Asian Americans. So you saw this grassroots effort bubbling up called Stop API Hate, largely originating out of a coalition of organizations in California, but this effort is now spread nationwide. We've also seen an increase in xenophobia, and unfortunately not only involving everyday residents, but also candidates for office and elected officials as well. And that has raised the temperature and unfortunately also seemingly have increased the incidence of hate across the country. API Data partnered with SurveyMonkey, which is now called Momentive, to try to get a better estimate of how Asian American and Pacific Islander communities have been faring with respect to hate incidents during the time of COVID. This was a survey that was conducted in March 2021, soon after the killings in Atlanta. What we found was that 27% of Asian Americans and 24% of Native Hawaiians and other Pacific Islanders say that they have ever experienced hate incidents, and we can talk more in the Q&A, and I think I have a slide coming up and that describes it in more detail, and that a significant proportion had experienced it since the onset of the pandemic, as well as in 2021. Reminder, this is from 2021, January to March of 2021. The way we worded the question on hate crimes and hate incidents, this was the question wording: have you ever been a victim of a hate crime? That is, have you ever had someone verbally or physically abuse you or damage your property specifically because of your race or ethnicity? What we find, and this is important, is that while certainly Asian Americans are relatively high on that score, especially with respect, higher than the national average and significantly higher than the white population, we saw that multiracial and African Americans, the Black population, had the highest level, saying that they had ever experienced these incidents. Importantly, Pacific Islanders also have a significantly higher self-report of hate crimes, as we defined it here, than the non-Hispanic white population. In addition to these hate incidents, where Asian Americans and Pacific Islanders score high is on whether you call this a microaggression or everyday acts of discrimination, having people ask where you're from, assuming you're not from the United States. So those are indicators where Asian Americans and Pacific Islanders score high. By the way, if you go to our website as well as the Momentive website, you will see disaggregated data, not by detailed origin. We didn't have sufficiently large sample size for that. We do break it out by East Asian, Southeast Asian, and South Asian for the Asian American population. And what we find is that when it comes to hate incidents, East Asians had the highest level, but Southeast Asians weren't far behind, and neither were South Asian populations. And the same is true for this everyday acts of discrimination or microaggression question. But when we have other indicators, other stereotypes, having people act as if they're afraid of you, we find that Pacific Islanders score higher than Asian Americans on this score in terms of everyday acts of discrimination. And then finally, when you look at other indicators like being unfairly stopped, searched, questioned, or physically threatened or abused by the police, Asian Americans have the lowest rates. Now, of course, we can and should disaggregate. And in this survey, if you go to the detailed findings, you are able to break it out between East Asian, Southeast Asian, and South Asian. We know from community reports that particular groups like Cambodian Americans do face higher problems when it comes to encounters with the criminal justice system and discrimination when it comes to criminal justice issues. That said, when you look overall, Asian Americans score much lower on this indicator than do Pacific Islanders, who also score lower than African Americans. Similarly, when we look at receiving poor service at restaurants and stores, Pacific Islanders score much higher on this than Asian Americans, who do score higher on this than the non-Hispanic white population. We also have breakdowns, if you go to API Data's website, in terms of disaggregating not only by detailed origin, but also by gender, by nativity, and by age. What our data show is that maybe the popular understanding that it's only elderly Asian immigrant women that are victims of hate incidents and hate crimes, our data indicate otherwise. In fact, what we find is that the native born are more likely to say that this has occurred to them. They may be less likely to report it to the police or even to community hotlines. And that, what our survey data suggests, is that there's a lot of room to go to make sure that younger AAPI populations and Asian American populations and the native born we need to increase the reporting among these populations about what is occurring. Finally, I'll say, going beyond the hate incident data, what we found when it comes to COVID deaths, some data suggests that from certain counties and states suggest that Asian Americans overall have a lower death rate due to COVID. But we followed the Marshall Project, which looked at CDC data on disproportionate deaths, and it showed that in several states, Asian Americans that had a higher than average level of disproportionate death in 2020 than compared to the prior 5-year average. You can find out resources on that on our website, aapidata.com. So I'll stop it there and look forward to the discussion later on.
Thank you, Dr. Ramakrishnan. Next, we'll hear from Ms. Thomas. Ms. Thomas?
Thank you so much. Talofa lava, everyone. Iamalia yatewe upu ilo ngutsu, mama faufawa ilo uloto. Olobi inga fo ilava iliatua, awale aise tasina timafaya on the suesuina on the siciliese. Amen. So discussing the conundrum of Asian American and Native Hawaiian and Pacific Islander data would not be complete without first acknowledging those who fought for NHPI data disaggregation before me. I would like to take this opportunity to pay homage to Clinton Helenihi, Victor Pang, Mary Salas, and the many NHPI advocates who wrote letters and testified at hearings to the Office of Management and Budget in 1994. NHPI advocacy played a significant role that led up to the revised OMB Statistical Policy Directive number 15 in 1997 that split Asians and Pacific Islanders, creating a Native Hawaiian and other Pacific Islander racial category, which set new federal standards for data on race and ethnicity. This community-led effort led to the first data collection of NHPI populations through the US Census in the year 2000, which really was a beacon of hope for the future of NHPIs who have been historically excluded in data. This milestone has allowed us to begin to better understand NHPIs, but we have to realize it's also just the starting point in advancing equity in our communities. Now today, over 2 decades since the 1997 federal mandate, there are still a number of data gaps that affect NHPIs and prevents communities, policymakers, and the general population from adequately understanding the full NHPI experience here in the US. These gaps in NHPI data can really be attributed to 3 main issues. And so the first is unavailable data, where federal, state, and even local agencies may not provide any NHPI data. The second is inaccurate data. So AAPI aggregated data does not paint an accurate picture of the NHPI experience, who make up probably 1% or less than 1% of this really large racial and ethnic umbrella. Under inaccurate data can also be the lack of up-to-date information on NHPIs, where many community members have to look back at old data from decades ago, which really is not sustainable or reliable. And the third issue affecting NHPI's data inequities is inaccessible existing data, where the data may exist, but isn't actually tangible, accessible, or even comprehensible at times to the people who need the data. Data systems, as we know, can be complex to navigate, and this continues to be a barrier for NHPI communities who rely on data to describe the population's need, and also results in a lot of consequences. So these 3 main issues, I think that the COVID-19 pandemic is really emblematic of them, and really of the widespread erasure of NHPIs in data, and the consequences of the failure to comply with equitable and racial data standards. So today, only 22 US states report NHPI COVID-19 disaggregated data on cases and deaths. Hawaii is the only state that disaggregates NHPI subgroups, which helps to identify COVID-19 disparities among Kanaka Maoli or Native Hawaiians and other Pacific Islanders. In California, which is one of the most densely NHPI populated states in the country, just a little over a dozen counties out of 58 report any NHPI COVID-19 data. COVID-19 vaccination data is also speaks to the inaccuracy of NHPI data widespread. In some regions here, like my own in the Inland Empire, NHPIs are mistakenly defined as having nearly 100% or even over 100% vaccination rates. So this can be really harmful and can make it appear as though NHPIs do not need public health intervention or support, when in reality, it's actually very contrary to that, and can be detrimental, of course, to the community's health. So finally, inaccessible COVID-19 data is still a challenge for community organizers and advocates who need this information to leverage it to decision makers, public health agencies, in order to gather resources for NHPI populations. And so I feel like data issues often can seem like, these are problems that might exist only on a computer or virtually, but they have, real life consequences for NHPI populations. Data on race and ethnicity, as we know, is integral to our understanding of health issues. And if we do not resolve data inequities, health disparities will only worsen, and communities like NHPIs and other small communities will grow more and more vulnerable. So in short, and as one of our previous speakers had written a paper on, there is no equity for NHPIs without data equity. So given that there are several issues, how do we even begin to think about resolving data gaps, data inequities, and issues for communities like NHPIs? And I know that we have a diverse audience, people who come from all different fields. So I have a few recommendations to make, beginning maybe with philanthropists and policymakers who might be here. I think my advice is mostly to invest in data disaggregation. NHPI communities and others, we cannot tackle this problem on our own, and studies often show that data disaggregation can be costly. So those who are committed to health equity, I urge to invest in data disaggregation, whether that be advocacy for data disaggregation or research efforts for data disaggregation. And in particular, investing in small communities like NHPIs, who almost act as canaries in a coal mine to understanding how data inequities can affect everyone. For researchers, engage NHPI communities and allow them to lead, allow them to be a part of the collection, analysis, and dissemination of data. At the NHPI Data Policy Lab where I'm at, which is at the UCLA Center for Health Policy Research, we came together during the onset of the pandemic to really address some of these data issues that I described. And we act as data intermediaries to bridge information to the community so that they may use this to create change. Some of our solutions have been creating platforms such as data dashboards that centralize and visualize NHPI COVID-19 data, which is used both for community advocates all over the US and locally. To those in public health, it's very important to continue or to begin, if you haven't already, collaborating with NHPI communities who have the aligned goal of advancing health equity and create equitable policies to disaggregate data to the extent possible. I know that there is a California bill that's set to be effect in next year that expands NHPI subgroup data disaggregation for Tongans and Fijians. So just a reminder to keep these new policies in mind and to ensure that they are implemented for NHPI communities and for all of those who are affected by that bill. Of course, to our Asian American brothers and sisters, continue to fight alongside NHPI communities in advocating for data disaggregation. And finally, to my beloved Oceania community, to continue to fight for the health of our people, because we matter no matter how small of our community that we are often labeled, and we deserve visibility and we deserve health equity. Looking forward to the remaining discussion and questions for the rest of the day. But yeah, thank you so much.
Hi, everyone. Dr. Moy got disconnected, so I'm going to step in and turn the microphone over to Dr. Dong for his presentation. Thanks a lot. Dr. Dong?
Yes, thank you, Kate. And it's an honor to be with the panel as well as for the session. I think my punchline, given the topic, disaggregation and the conundrum, is responsible disaggregation. And let me share with you how I get there. Certainly with this group, it's a shared voice in terms of the purpose for data disaggregation. I'm wearing my hat as a survey researcher, as a population epidemiologist, as a clinician. And when you're thinking about disaggregation versus aggregation, there are times for each. And as a survey methodologist, when we think about how best to responsibly disaggregate data, you have to think through the lens of how do you use the data from that perspective? Cultural concepts are really important to be able to understand. So if you disaggregate data, but doesn't really get to the root issues from a cultural perspective, what you're trying to understand, just because we have 15 different data fields, suggesting different Asian ethnic groups plus more, doesn't necessarily mean the rest of the data that you're trying to understand the relationship with is meaningful. For example, how do you study the concept of filial piety across different Asian groups? How do you compare and contrast the concept of Hong in a traditional Korean culture in a South Asian context? How do you study the concept of religiosity in a Filipino and South Asian population relative to a Chinese or Korean or Japanese population? So I think culture concepts are really important to be able to understand when we disaggregate data, what kind of causal inferences are we trying to set? The second is measurement. I think there's a tendency sometimes just to say, well, let me just translate the measures and to be able to understand that. It's very difficult to do that, number one, not just from a translation perspective, but from a psychometric perspective. I think we really have to understand data disaggregation when we measure concepts across different racial ethnic groups to make sure that the psychometric properties for those measures holds true. We can't just simply interchangeable a term from a English language into 20 different Asian groups and assume that's sound and measurable. I think even within that setting, when you look at, South Asian population, Indian, for example, Hindi versus Gujarati, translations are very different. We can't just even assume even within a specific racial ethnic group that they're homogeneous. Another issue with respect to disaggregation is understanding access to the community, right? When we collect data, we can't just assume that we can collect those data in the community, having access to them without partnership, without sustainable partnership, in a way that community can be just as invested. Another point with respect to the conundrum is analysis. There's a saying that I say to my team quite a bit, it's garbage in, garbage out. If we don't think about those issues during the construct of a survey, understanding how to frame data, when we start looking at data analysis is much less meaningful, not alone to say the interpretations of those data with respect to understanding cultural values, which is the area that I spend a lot of time thinking about. How do you compare and contrast cultural values across different groups when the data is are disaggregated after that point? Equally important, the last point is how do we think about policy impact from understanding the data that we have collected, that we have synthesized, that we have interpreted, we have published. It doesn't necessarily mean just because we disaggregate data that the policy or practical impact is going to be there. Using PINE study that our moderator spoke about is a population cohort study right now over 4,000 people has been followed for about 6 waves of the study over the last 12 years. When you do a Google search of PINE study, there are probably close to about 500 citations between original manuscripts and abstract that's being presented. We have enormous disaggregate data specific for Chinese population, but yet when you look at the impact, it doesn't necessarily translate, so which will lead to my recommendations a little bit later. So that's the first part. The second part is really, we can't think about disaggregation versus aggregation without thinking about workforce. When you look at responsibilities of funding agencies and think about diversity, equity, inclusion, there's a vast gap with respect to funding for Asian studies. We've done some analysis through some of our centers here at Rutgers that over the 10 years, NIH funding, research studies being funded primarily to study Asian populations is less than 1%. When you think about that data as a whole. Asians are not often included in NIH and NSF in terms of underrepresented minorities. And yet when you look at some of the specific social sciences and behavior sciences related field, that we are 74% less likely to receive funding from those agencies. So there's a vast gap in those areas as well. Currently, there is a National Academy of Medicine consensus panel to improve diversity for women and underrepresented minorities. The report will be coming out sometimes later this year. And there's a lot of recommendations there that will be forthcoming. But I think to step back before I get to recommendations specifically to this, is that we cannot singularly address the issues of desegregation without thinking about broader diversity, equity, inclusion for underrepresented, underserved populations as a whole. I'll give you an example. Asian health certainly of critical importance to not only to my work, but all of your work here. But that's not appreciated necessarily in a traditional academic environment. When you think about promotion and tenure, many folks in our academics are measured by grants and manuscripts. It does not necessarily treasure the amount of time and effort necessary to really meaningfully sustain community engagement. Without community engagement, without buy-in, without that sustainability, whatever we do as a group here in terms of thinking about desegregation will not be long-lasting. And I think we have to fundamentally change the academic paradigm in thinking about community engagement, not just for Asians, but for Hispanics, for Native Americans, for African-American population as a whole. And I think to make that meaningful to us over time, I think we have to shift in paradigm. I think we have to invest in pipelines as well as faculty support. To an initiative currently going on Rutgers right now out of the Institute for Health, we host 2 NIH-funded center grants. One of them is a P30 center grant. It's the Asian RUCMAR, known as Minority Center for Aging Research. It's a National Institute of Aging-funded P30 mechanism. Another grant that we have was an NIMHD-funded P50 mechanism, which just got funded about a few months ago back to study cardiometabolic and mental health in Asian American populations. Those kind of center structures provide sustainable support for junior early stage investigators, because in academics, as you know, that funding still often valued much more than teaching and sometimes more than patient care, depends on which specialty that you are. And when faculty submit grants, you know, they're being told that if you study too disaggregated, you're not generalizable enough, right? And if you study too generalizable, you know, population Asian as a whole, it does not get to the culture nuanced issues. In many ways, damned if you do, damned if you don't, with respect to submitting NIH proposals in this case. And having structures such as P50 and P30 mechanisms be able to support faculty in a very different way. And the last thing I want to say is that some of the examples that we're doing, I think our moderator, Dr. Moy, talked about the New Jersey cohort study, is that we're studying 8 different immigrant groups. And for us to do so, really to get at disaggregation, because in New Jersey is very unique, even though it's one of the smaller states, one of the worst disparities in the country. But it's also one of the fastest growing immigrant groups in the US. We're 3rd largest percentiles. When you look at total numbers, we're the 5th or 6th, even though one of the smaller states. But to be able to do justice to data disaggregation, there's a tremendous amount of resources that are necessary to do it right. It's not just translations, cognitive testing, it's psychometrics, understanding culture concepts. All of those things really needs to occur in the early phases of a study, which may or may not be feasible for using existing data sets. So let me stop here, Dr. Moy. Let me turn it back to you. I think at the end of the day, people may have more questions.
Thank you, Dr. Dong. And I've been told that Dr. Moy had problems with his internet connection. So this is Dr. Wong again, and I'll take us to the end of today's first webinar session. So it's been very reinforced throughout this panel, as well as several other speakers, that data disaggregation and a much more sophisticated and intentional aspect of looking at Asian Pacific Islander Native Hawaiian data is kind of a critical strategic imperative with regards to achieving equity for the Asian American Native Hawaiian Pacific Islander populations. And I think all of you kind of really gave us some insights around that. So I want to surface some of the aspects of how that becomes operable in terms of making this a real imperative in terms of our policy work moving forward, and ultimately really improving the health of Asian Americans, Native Hawaiians, and Pacific Islanders. So Ms. Davis and Dr. Ramakrishna, you mentioned issues around AAPI, Native Hawaiian hate crimes, and how that's reported. Is there anything we can learn with regards to how that data has been reported relative to community groups as well as individuals that can help feel a new way, new approaches that would go even beyond the reporting of hate crimes during this period of increase in xenophobia?
Thank you, Dr. Wong. I just want to maybe just dig a little deeper. I want to make sure that I'm fully understanding where you're going with that question. So could you just elaborate a bit more?
Well, as I understand, a lot of this, the data has been promoted relative to reaching out to individuals, like even your slide about please report AAPI hate. And is there lessons that we can learn that would be applicable to other public health things in terms of self-reported data or using surrogates to help bring the data forward? Is there
Absolutely,
issues there?
Great, and I'll maybe take it even one step further. I didn't have much time to introduce myself, but in addition to being a professor of public policy and as a researcher, I also chair the California Commission on Asian and Pacific Islander Affairs. And our commission, working with the API Legislative Caucus and a coalition of over 300 community organizations, pushed for an API equity budget that had data equity as part of it, but also investments in the Department of Social Services with outreach grants to community-based organizations. I think this will get at some of where you're leading this question, Dr. Wong, which is, yes, a lot of these are experienced at the individual level. They're also experienced at a household level and at a community level when we think about community trauma and also anxiety. What makes this even more complicated is the news reporting and maybe even some of the sensationalism, the selective kind of social media on repeat kind of imagery also creates anxiety and trauma in communities. So what do we do, right, to make a difference here? Part of what the state of California is trying to do, and our commission is helping the California Department of Social Services with this, is to increase awareness about the kinds of services that AA and HPI community members are entitled to, but have not accessed for various reasons. Some of it may be because of taboo. Some of it is because of policies like the prior administration's public charge policies that made people reluctant to access care because they might not get naturalized because they're accessing state level services. And some of it is simply lack of awareness. And there are many other potential factors as well. So when we think about what does it take to make sure that people are not only when they experience something to be able to report it and get assistance connected to it, but even more generally to understand the range of services that are meant to serve them, but our communities have not accessed for various reasons. And some of it is not just things internal to the community, but the way that these systems are built that make them inaccessible to members of our community. We're actively trying to understand all aspects of that and to see what state government agencies can do to be more proactive in providing, as Dr. Dong mentioned, that kind of linguistically appropriate, culturally relevant and resonant care to our communities. So what we saw is for too long, even in a state like California, where AAPIs represent about 1 out of every 6 or 1 out of every 7 residents, depending on how you count it, we are still very far behind where we need to be in terms of serving our population. So I'm hoping that helps answer at least part of the question there.
I think it's really interesting to touch upon the aspects of community-based organizations identifying gaps in service as a vehicle in which we actually start to understand how data can be extrapolated from the lack of utilization or perhaps the overutilization of certain services. Ms. Davis, did you have any further comments? Carla, excuse me.
I think that, like you said, communities are so essential in making data equity happen because their testimonies and their stories match what is seen in larger numbers. And they bring the story, they bring the human aspect to data. And so that's why community leaders and organizations are so important in the fight for data disaggregation. So as I had mentioned previously in the presentation, I think that it's so important that all stakeholders engage AA and NHPI communities, whether that's investing in their advocacy efforts, where they're lobbying to fight for policies that disaggregate data for them, or partnering with research communities that also fairly include AA and NHPI communities in data disaggregation research efforts. Thank you.
Dr. Dong, you touched upon this in your remarks with regards to issues of disaggregation that might apply to the increasingly heterogeneous populations of Latinx and African American Black populations. I was wondering if you might elaborate on that. Is there an opportunity to really engage in this issue of disaggregation of data across different groups beyond the Asian American, Native Hawaiian, Pacific Islander communities? And if so, what have you seen in that policy direction?
Yeah, no, great question, this thing. I think I can speak about the research perspective and then come back to the policy. For the New Jersey cohort study that we mentioned, we're studying not only African American population, but also study two very unique, one is the Caribbean population from Haiti and Dominican Republic, which often they're considered not only Afro-Caribbean, but I think it's much more complex than traditional paradigm thinking about African American population. Also, we're studying Nigerian population, Ghananese population. I think to be able to understand the heterogeneities even within African American Latinx population is enormously important. When you look at SO study, when you look at MESA, the number of the cardiovascular study have shown repeatedly the heterogeneities within the Hispanic population as well. So I think there's a lot of unique opportunity to do that. I think getting to the root causes of why, I think that's the complex part in terms of understanding. To give you another example, looking at depression screen. Most people use geriatric depression screen in my aging population, but yet it's neither sensitive or specific enough to measure depression in many East Asian populations. So if you disaggregate data from racial ethnic perspective, but does not understand the outcome of interest, then he may just come out as saying, well, when we disaggregate data that, Chinese population have no depressive symptom because it doesn't measure right. So from a policy perspective, I think we have to be able to provide community organizations that Carla's talking about, tools to collect data accurately. Many of the community organizations, especially Asian American population, do not have infrastructure to be able to collect data in a way that can enable their needs as well as the broader needs as a whole. I think we can talk about resources all day, but the reality is the resources limited. We're not going to get $1 billion to do this initiative, right? As much as we'd like to do so. I think as academic medical centers, as healthcare systems, as philanthropists, I think we need to give community organizations tools to collect the data and working with community partners as well as academic institutions to advance those goals.
Oh, those are really important recommendations, Dr. Dong. We have a question from the audience with regards to issues around the quote, and I emphasize quote, the territorial status of some of the Pacific Islands and the communities, the populations. Is it an additional obstacle burden with regards to the different relationships of the Pacific Islander communities vis-a-vis COFA and or whether they're just from other countries in the Pacific in terms of capturing accurate data?
Yeah, I think that there's definitely an introduction of even more complex data issues when you take into account the diverse Pacific Islands that have affiliations with the US. There's many different relationships. American Samoa itself, it has a different relationship than Guam, than the Federated States of Micronesia, and so forth. I think that one of the milestones to highlight for the COFA community is the Medicaid restoration that was implemented in December 2020 and still lacks in being able to fully enroll all COFA folks in the US in Medicaid, despite it being passed. And so that speaks to the data inequities that many COFA migrants face today, because state and federal agencies cannot adequately identify where they're located, and therefore they cannot enroll them into health coverage, which is extremely important considering that COFA communities have been extremely impacted by the COVID-19 pandemic because of occupational reasons, of familial and household composition reasons, and so many other reasons. But to sum up, I think there are more complex data issues when it comes to these other territories of the US. I think that's a really great question. And I know, there's definitely a lot of organizers in these different places that continue to fight for better data. But yeah, that's something that we still need to venture.
We just have a couple of minutes left, and before we wrap up this really great and critical panel discussion around data disaggregation, I want to ask each one of you in 30 seconds or less, what would you make as an expert in disaggregation recommendations about moving forward on this critical issue? Let me start with Carla, if you will. Can you think of one last comment around a recommendation, 30 seconds or less?
Yeah, I think that my recommendation to sum up would just really reiterate that data disaggregation for NHPIs, although it's we're a small community, this affects so many other communities who are considered small, who are considered statistically unstable when it comes to numbers and not having sufficient sample sizes. So this is not a fight of just NHPIs, but for the entire population. And if we support small communities like NHPIs and data disaggregation, we'll eventually reach and advance health equity for all communities.
Nicely said. Dr. Dong?
Thank you, Wednesday. I think when to disaggregate data, when not to disaggregate data, I think that's important. And I think that's from a more of a research perspective. From advocacy perspective, I think we should always lean sometimes on the benefit of the doubt of aggregating data, because I think collectively as a group, as Asian Americans, I think we have much greater power, because I think, as Carla said, when you may be able to include Filipino population, but the sample size of 20 as opposed to the sample size of 5,000, what does that mean? So when to disaggregate, when to aggregate.
Thank you. And finally, Dr. Ramakrishnan.
Thank you, Dr. Wong. I would say recognize community expertise as well as expertise that's been built up among scholars for years, if not decades. Also, disaggregation is part of a larger push for data equity, and what that looks like for different communities will look different. But absolutely, in addition to disaggregation, it's investing to collect valid samples of our communities, as well as with the questions, to analyze it, and importantly, as Carla mentioned, to give it back to the community, to make it accessible, especially community organizations and the people on the ground, right? It's not just, speaking as a scholar myself who knows how to pull down microdata and analyze it, it is not sufficient to just leave it at that. It has to be shared. And then finally, for the National Academies, as someone who was part of a consensus panel on immigrant integration, I know a couple of my colleagues were very interested, and I know that the National Academies is interested in trying to produce a consensus report in terms of AA and HPI populations and what that kind of research agenda needs to be, as well as potentially a larger public policy agenda as it involves federal agencies. That cannot happen soon enough. It needs to happen, and I hope it will happen in the next year.
Wow, great recommendations. We've wrapped up a great first day of our two-part webinar. To a question from the audience, this Thursday webinar is not identical to this first webinar. We even have greater opportunities to elaborate, including some speakers and Helen Zia, who provide a narrative around issues about history and the development of the model minority. Certainly Juliet Choi from the Asian American Pacific Islander Health Forum in terms of looking forward. I'm asking a favor of all of you who are still part of the audience now. Please, please network and ask your friends and colleagues to register for the next Thursday, this coming Thursday's webinar, because it's important for us to demonstrate that this is of great interest in the public health community. The greater numbers that are registered, that really reflects the interest and importance of this subject. So until Thursday, I bid everybody a good afternoon, and thank you to our great panelists for an invigorating day. Thank you very much.